Morning to you all. I welcome you all on behalf of PSNM to today's first scientific session. Without much ado, I would like to call upon Dr. Javed Irfanullah, chair for this session, to take his seat on the stage. I now request Dr. Iftikhar Alam, who is the co-chair for this session, to please take his seat on the stage. Thank you, sir. Our first speaker is Dr. Moiz Malla. Dr. Malla is the distinguished chair as well as the director of cardiovascular PET and associate director of nuclear cardiology at Houston Methodist DeBakey Heart and Vascular Center, Texas. He is also professor of cardiology at Houston Methodist Academic Institute Center. He is the immediate past president of ASNEC. He is a member of several American and European cardiovascular councils and editorial boards of cardiology journals. Please put your hands together to welcome Dr. Malla. Over to you, sir.
Thank you very much for your kind introduction. Just wondering if you see my slides and they're well seen. All right, so I'm going to be talking about nuclear cardiology, where we are and where we are heading. And first, I want to thank you for the kind invitation. I want to thank Dr. Anam and everyone for hosting me today. And I've seen some of the sessions from the recordings, and I want to congratulate you on a great conference. Looks like you had terrific sessions in the past couple of days. I hope this last day is no different than before. All right, so what's happening in nuclear cardiology? I know Dr. Arif in the first day mentioned a lot about what's happening overall in nuclear medicine, and nuclear cardiology is no different. In fact, if I want to count what's happening in terms of new advances in nuclear cardiology, we see a lot of newer advances. I hope in the coming 20 minutes or so, I just want to quickly cover some of these innovations that I highlighted here, and you can see. There are advantages in cardiac PET, hybrid imaging, newer tracers, newer cameras, AI tools, infection, inflammation imaging, myocardial blood flow, and amyloid. Obviously, this is too ambitious really to cover all of them in 20 minutes, but I'll give it my best shot. The first one is that newer technology, which you know a lot from others. This is how SPECT CTs used to look way back, probably around 50 years ago or so. And now we've moved on from SPECT to even SPECT CT. And what that has given us in cardiology, in nuclear cardiology per se, a lot of advantages. The first one is that we're now able to do routine attenuation correction. And the impact of that it allows us really to reduce artifact and enhance specificity. And if this is not routinely done, I don't think this is, it has to be routinely nowadays done in our patients. And this is from the guidelines that we put a couple of years ago, the multi-societal ASNIC and SNMMI guidelines, where we've shown that using attenuation correction enhances the specificity of nuclear SPECT imaging. You can see that we go up in terms of specificity from 68% all the way to 83%. But now that's not the only advance we have. Now we have even CZT SPECT cameras, which I know that some of the centers that you have some of the D-SPECT and some of these. And this bring a whole new advantage of allowing you to do more efficient imaging, even with lower doses. And this is the experience of one site in the United States where they were able to get a CCT camera and then followed by a second CCT camera. And now you can see that the amount of radiation, the exposure of these patients have dropped to about 2 millisievert in the median once they got using these new cameras, because you can inject very low doses even among obese patients. So this is one major advantage. But someone can say, what is the state of the art of SPECT in 2024? If I want to claim that I'm doing SPECT to its best in 2024, what should I be doing? First of all, we need to have tools to allow us to do better specificity and less artifacts, and that is attenuation correction. And to me, I feel very strong about this. We need to use this tool to allow us to do adequate imaging. We also need to have concomitant assessment of atherosclerosis. You can either look at it on a dedicated calcium score, or you can look at it on the CT attenuation correction. And I think Dr. Nabi is going to cover this in a whole talk after this. We can utilize low-dose protocols like stress-only imaging, or use the new cameras to acquire that. Or finally, we have to try to assess myocardial blood flow in some patients, because for many years we focused a lot on ischemia. Just our burden was, I will do an MPI study and I will say, well, this is ischemia or no ischemia. Well, now there are way more nuances to that. It's not enough to say that the patient has ischemia or not. We need to know if the patient has atherosclerosis or not, or if the patient has mild atherosclerosis but no ischemia, or if there is atherosclerosis and ischemia. I think it's very important to know that. It's not acceptable just to call it ischemia, no ischemia. And this should be routine now in our reports, to say that, to look at the CT and say, well, the CT shows calcification, this patient had atherosclerosis. That's one paradigm shift that we should see on our nuclear reports. Cardiac PET is growing in the US and across the world because of many reasons. I know you have many PET scanners in Pakistan, and you are able to acquire to do a state-of-the-art oncology imaging. But for MPI, cardiac PET provides you with a lot of advantages, given high diagnostic accuracy, high quality images, low radiation protocol, short acquisition protocol. But I think one of the main advantages of cardiac PET here is that cardiac PET allows for quantification of blood flow and has strong prognostic data. Given all of that, I think that cardiac that should be offered in a country like Pakistan. I've seen some of the numbers that in the first session that you've seen about the number of scanners that you have, and I know this may be challenging that you may not be able to offer PET because of cost and volume and access, but now we have newer tracers that hopefully will allow us to do more, even in the low volume labs, as long as you have newer centers. And this is what I meant by that, is flurpiridaz, which was just approved by the FDA a few weeks ago, and hopefully it will start to go commercial in the US soon, and followed up by that around the world. It has a lot of advantages since it uses F18 as isotope. It only needs a regional cyclotron, which allows you actually to be able to transfer it, like you guys get your FDG doses from one cyclotron that can be supplying it. And this way you are able to use the cyclotron to produce multiple doses and supply multiple centers in different parts of the country. And it is for sure it has higher sensitivity compared to SPECT. This is, for example, a case where the SPECT images did not show any ischemia, but when flurpiridaz PET was done, there's clearly significant ischemia that's noted in the anterior wall. Here's another case where it was actually more concerning that there might be ischemia in the inferior wall, but in reality there was none. And we know from data that was recently presented and published by Dr. Madahi that compared to SPECT, PET with flurpiridaz have better accuracy overall. And this is another case where looking at it, you may not appreciate much of ischemia there. And this is how it was read. But when you look at it, you can clearly see with flurpiridaz that there is significant ischemia in the inferior wall, which was not, and here's back to the SPECT images, which was clearly not seen. And now we can see the amount of ischemia, and you can see on angiogram the patient has tight stenosis in the RCA, in the right coronary artery at multiple levels. So this type of tracer will allow you to get on a unit dose. It allows you hopefully to do myocardial blood flow. You may potentially be able to do exercise PET with it because it has a longer half-life. And I think in a country like yours, if only there is one cyclotron that's able to produce it, it can be shipped to multiple parts of the country, similar to the current distribution of FTG that you have. This is not the only F18 tracer that's currently, this is the only one that's approved, but there are multiple ones that are currently being developed. This is one which is done in China, which I would call the Chinese version of flurpiridaz. And now they just published phase 1, phase 2 has been completed, and they're about to start their phase 3. So hopefully within few years, you'll have not only one option, but you will have multiple options that will allow you to do cardiac PET in your country, and hopefully be able to offer that to your patients. And if you ask me, this is something that's very encouraging, and there is actually a third one, which is also currently being developed in Poland, and there will be a third tracer, and the phase 1 is currently being reviewed, and the phase 3 is actually enrolling in these patients. And this is the image quality from the phase 1 publication of that Chinese version of flurpiridaz, and you can see here the image quality, how great it is in this patient. So now your doctors are looking, your cardiologists, your referring physicians are looking in their guidelines, whether they're coming from the base, they're looking at the USA guidelines or the ESC guidelines, and both of them have multiple class 1 indications for cardiac PET, but also for myocardial blood flow reserve or CFR to help you in the assessment of patients. In fact, the European Society of Cardiology, which is equivalent to ANM, but this is for the cardiology group, the cardiology patient, your cardiology doctors look to these guidelines. Now they are being told, and this is just published and presented in ESC in London a few weeks ago, where it shows that PET is preferred to SPECT. And here it says measure calcium score. And this here it says, but MPI is helpful to identify patients at high risk of adverse events. So all of these doctors are gonna come to you and ask you about these. And I know in the meantime, you don't have PET to be able to offer to your patient to assess blood flow, but I think you can do it with SPECTs. And I know that we know that many of these patients who have chest pain have microvascular angina. About half of them in this study actually tend to have microvascular angina. So these patients who have chest pain, they come to their heart doctor, they're having chest pain, we do some images, SPECT, and we don't see anything. If you look at them, especially in a country where you have diabetes, obesity, smoking, you will be able to diagnose many patients with microvascular angina if you do SPECT myocardial blood flow. And I don't have much experience with that. I know Dr. Inam is doing a lot of that kind of work. And this is one case that was lent to me by Dr. Prem Soman, where you can see that the perfusion imaging was pretty much normal. But when he looked also at the flow, this is a patient who has normal flow there. And now you can see on the angiogram that there is no obstructive disease. So it's kind of like normal at every aspect. It shows you that we are able to quantify blood flow. And when this was looked at in terms of accuracy compared to PET, it was reasonable accuracy. And there's about 10% difference in terms of the numbers that you get with PET. So it may not be your it may have some limitations, but I think in the absence of PET, this would be a good reproducibility. Is it ready for prime time? I think it will not be as good as PET, but in the absence of PET, this is the way to go. It provides useful additional information. I think serial imaging may be a little bit still need to be studied because we don't know how multiple measurements would look like, and then obviously you will learn from Dr. Inam that there will be significant throughput considerations needed since you're going to be requiring to do these patients in different times. So I think for ischemic heart disease, which I think is going to be the most of the applications we do, these are the major advantages that you see here. Now, there are some new other applications that I will share with you from artificial intelligence. Now, there are software that allows you to do AI-based attenuation correction. So here you, for example, you see a SPECT with an inferior defect. You think it is diaphragmatic attenuation. They did attenuation correction using CT and it looks perfect and there was nothing in there. But when they also did deep learning attenuation correction, it gave you similar results to the attenuation correction by CT. And the accuracy was pretty much very similar to between the attenuation correction done by CT versus deep learning. And this is another software, but now here they do it with polar maps, and here's a defect, and goes away with attenuation correction and goes away with deep learning. And now on the CZT camera, this is actually a product which is available in the US, and it is actually that you can, it's called TrueCore, and it is, you can potentially use it clinically and FDA approved, where you see an inferior defect here, it gets better with attenuation correction, but also CT attenuation correction gives you similar results to what you see with the CT attenuation correction. So hopefully that will help you pick up on these. But there is a whole slew of non-coronary applications that are growing in our labs. And in fact, in my lab now, there are 25% of our work that we do. For example, we do a lot of amyloid imaging. I'm not going to talk much about it, but what you can see is that among patients that we suspect them, whether you do PYP or DPD imaging, you can see an uptake favors ATTR. But I think I want to make a point here is that now I personally think, and the guidelines encourage you to do SPECT CT. In my opinion, it's a must. So if you want to diagnose amyloidosis, ATTR amyloid, you need to have a SPECT CT. We also have growing applications for endocarditis, and this was boosted by the recent guidelines and the recent criteria, where here you see an example of a CT and there is a hypoattenuation there, and this turned out to be a very hot uptake in endocarditis. It's very important to keep in mind that this is only for prosthetic valves, for native valves, but not the prosthetic ones. The sensitivity is low, so I always tell my referring physicians that if I see it, it's there. If I don't see it, that does not mean that the patient does not have endocarditis. And now we got a big boost from the criteria for endocarditis where CT and PET imaging are major criteria for diagnosis of endocarditis. So both PET and cardiac computed tomography, both of them are considered major criteria for diagnosis of endocarditis, where many years ago it was primarily echo. Now we have echo, but also CT and PET, which is a major advantage for these patients for diagnosis. And the European guidelines also gave it class 1 here, where you can see here FTG, PET, and CT are recommended in patients with prostatic valve endocarditis to detect valvular lesions and confirm diagnosis. Class 1. So this is what your cardiologist, a referring physician, or ID doctors read, and that's why you will see many of these applications, and you can start to implement them today. In comparison to white blood cells, SPECT-CT, for example, it's a longer procedure and it's given a class 2A indication with level of evidence C, and only if there is PET-CT is unavailable. If you have PET-CT available, that would be a better option for you. We also diagnose inflammation. We can look at it in the aorta. We can look at it in the pericardium. We've seen pericarditis uptake. We've seen aortitis uptake. We've seen also myocarditis, and the myocarditis may be from sarcoid, maybe from something else. And it's very important for us to make the diagnosis. We combine it often with MRI and potentially fuse it, as you see here. But you can also see that we look beyond the left ventricle. We can see it also sometimes faint uptake in the RV. In this patient, for example, we see it in the left atrium, and you can see this intense uptake that we see here. You can also see that we can see it in extracardiac uptake, like lymph nodes, sometimes in the lungs, sometimes in the liver, sometimes in the spleen. But it's very important to make sure that the patient is well prepped for these type of studies. So it's very important to know that, because we don't want to overcall. This is a patient where we did perfusion imaging. There might be a small basal perfusion defect, but the patient has diffuse uptake there. When we told the patient to be prepared better without any treatment, now you can see that there is no uptake actually in the myocardium. So we've done a study to look at this, and we found that using beta-hydroxybutyrate test, it will guide us to identify which patients are actually well suppressed. And what we are using is a cutoff of 0.4. I would say that probably it is between 0.4 and 0.5 where the cutoff. We had few cases that we called false positive despite being above 0.4. But you can see here that with our experience that it's about 0.4 where most of the time you are correct. If you do it and the beta-hydroxybutyrate it's less than 0.2, you're way more likely to be false positive rather than true positive.
Sorry to interrupt, sir.
And inflammation, you can assess impact to therapy, and you can look at it quantitative, or you can look at it qualitative and quantitative like you do with cancer, where you follow SUVs, volume of uptake, and others. I want to finish up with one last caution word, which is not every FTG uptake is actually inflammation, is sarcoid. Some of it may be actually other cardiomyopathies. In this case, for example, it was amyloid that had some uptake. And there are some genetic mutations which may potentially have inflammation uptake. So not everything that lights up is actually gonna be sarcoid. You can still have to look in the clinical diagnosis, and sometimes may need tissue diagnosis, although it doesn't need to be the heart, but at all you can look and identify, for example, and do also some genetic studies. So it's very important to convey that message to your referring physicians. So what's going on? There is a lot going on in nuclear cardiology. In terms of newer technologies, we have cardiac PET, new tracers, flow assessment, atherosclerosis assessment. There are many AI tools that are being available for us. And now there are new non-coronary applications, including amyloid, inflammation, and infection imaging, which many of these were not on the menu for us about a few years ago, and now the list is growing, and I expect the list to even grow more in the coming few years in terms of imaging and applications of nuclear cardiology. Thank you for your attention, and thanks for having me. And if you want, we have a WhatsApp group that you can happy to join and learn about our activities and what's happening in there. So I'll leave this here, and I'm happy to take any questions. Thank you.
Such a riveting talk by the stalwart of nuclear cardiology. Thanks a lot, Dr. Malla. If there are any questions in the audience. Dr. Mehdi.
That was a great enlightening talk early in the morning here by Professor Malla. We thank you for enlightening us. I would like to ask about the deep learning software that you talked about, because we have learned over time and experience that the attenuation correction has its own challenges. So how much do you consider the deep learning or the artificial intelligence softwares that are available like TrueCore reliable? Do we trust them entirely, or we have to pass through a learning curve and get to know the pitfalls and the pearls of these softwares? Your views and comments.
That's a very wise question coming from a wise man, and I think this is for everything there's a learning curve for sure. These are new tools, and with AI there's always a risk of this issue of black box, that we don't know what they are doing and what they are, but the accuracy data that has been published on this, and it's a multi-center study with core lab read, and it looks like it is encouraging in terms of assessment. I'm sure there will be some pitfalls. I'm sure there will be some scenarios that you want to be careful about. But I think overall, this is going to be very encouraging to go ahead and potentially utilize it. The other two are mostly in research at this time. They're not commercially available. TrueCore is the only one that's commercially available. The data is encouraging, I would say, but obviously you have to learn. There's a learning curve for everything, so it's very important to kind of gauge where it works and where it may potentially fail.
Thank you, sir. Are there any more questions? Dr. Nomer, sir, please.
Thank you very much, Dr. Malla, for an excellent talk. I have two questions. One regarding the diagnostic accuracy of using fluoridipase for the detection of the coronary artery disease against the CZT-based SPECT-CT imaging. Because here I think the diagnostic accuracy has no one-to-one comparison studies available for both the modalities. And my second question is regarding the use of CZT-based SPECT-CT for the detection of the coronary artery disease. How do you see it in the future, comparing it with the arrival of this new agent for PET now? Thank you.
Yeah, so these are also very important questions. The first one, in terms of comparison of diagnostic accuracies, there is obviously no head-to-head comparison. The study that was done included mostly regular Anger cameras in terms of specs, so it's also an unknown question there. One thing I have to say, that in all fairness to the flurpiridaz trial, the images were mandated by the FDA to be interpreted without blood flow assessment, which we usually do look at, and wasn't done in terms of assessment of calcium score too. So it's not really the full calcium, the full cardiac PET option that we usually do in clinical practice. But also for CZT, you may be potentially able to get some flow data. So that might be a good, hopefully, comparison in the future. But at this time, it's the most of the comparisons are with regular Anger cameras. In terms of the future, in terms of utilizing it to diagnose coronary disease, I personally think that PET will have an edge always because of the type of isotope, the accuracy of the images. But I think if a good CZT based acquisition may have, the only problem with the CZT acquisitions are that they are lower counts. So when you have a lower count scan, you have so much variability in there. And that's the biggest question going to be, how reproducible are these numbers across time? And when you make the diagnosis. So a lot of this is not known, but my bias, I would think that PET will have accuracy. The question is, how much is the delta between flurpiridaz and SPECT-based? It's definitely not going to be as much as using a non-attenuation correction Anger camera. CZT gives you better image quality and it enhances your ability to diagnose, especially when combined with CFR assessment. But I think, does it reach to be like PET? I don't think so. There will be some limitations to that unless we get newer tracers that will help us to do lactoperoxime and others. But with current technetium-based tracers that we have for MPI, even with CZT, I think there will be a challenge to meet the demand of what we need.
Are there any more questions? Thank you very much, Dr. Malla. We'll proceed to our second talk of today. Our second speaker is Dr. Faisal Nabi. Dr. Nabi is a reputed cardiologist at the Houston Methodist DeBakey Heart and Vascular Center, Texas. He is assistant professor of medicine at the Vail Medical College of Cornell Uni. He has special interests in preventive and general cardiology, as well as stress testing, cardiac CT, and nuclear cardiology. Dr. Nabi is a member of American College of Cardiology, American Heart Association, American Society of Nuclear Cardiology, and the Society of Cardiovascular Computed Tomography. His interest is evident in the number of times I said cardiology in the last sentence. He is a fellow of American College of Cardiology. It's an honor indeed to welcome our famed Dr. Nabi. Over to you, sir.
For it, number one, it has very good diagnostic. Assalamu alaikum, everyone. It's a real privilege for me to be able to speak to you today on the added value of calcium scoring to perfusion imaging. I'd like to thank Dr. Noman and the rest of Pakistan Society of Nuclear Medicine's organizing committee for this tremendous opportunity. So we've known for a long time that SPECT has been a workhorse for the assessment of chest pain. And there's very good reasons for it. Number one, it has very good diagnostic capabilities, as well as this slide on the top right corner shows, that it has good prognostic value as well. As the degree of ischemia increases, patients have increasing cardiovascular events. Similarly, those findings of diagnostic and prognostic value have also been shown with coronary artery calcium scoring. We know calcium, when we see it in the coronary arteries, identifies the presence and extent of atherosclerosis, and it correlates very nicely with total plaque burden. And we know from the slide that we see in the top right-hand corner that as your calcium score increases, your risk of having a cardiovascular event progressively increases. Whereas those patients who have a calcium score of 0 have an excellent long-term outcome. Now, more and more scanners in today's market are what we call hybrid scanners. They have both a CT machine that's attached either to a SPECT or a PET scanner. And the CT allows either attenuation correction, radiotracer localization, or the performance of a calcium score. But it also allows us the opportunity to evaluate both myocardial perfusion and an anatomical assessment of atherosclerosis with calcium scoring as part of the same exam. And for the rest of my talk, I'd like to show you how the combination of nuclear medicine for a functional assessment for ischemia and a non-contrast CT scan for coronary atherosclerosis combined can improve diagnostic accuracy, can improve risk stratification, and also possibly improve outcomes. So I'm going to begin with a case. This is a 52-year-old with a BMI of 40, hypertension, who was seen for a pre-op prior to surgery. And you can see this fixed perfusion defect on stress and rest images across the anterior wall. And if you look on the bottom right, you can see there's normal wall thickening and ejection fraction. I think most of us would feel comfortable given this patient's body size and what we're seeing on the raw cine data, that more than likely that this is simply attenuation. But the question that I have for you is, does your confidence increase if I showed you the patient's calcium score? And here the patient had no demonstrable evidence of coronary calcium. So I think you'd all agree you'd feel much more comfortable that this was due to soft tissue attenuation rather than due to coronary artery disease. And of course, this patient also had undergone prone imaging, and you can see on the prone images, which are the middle set of data, the perfusion images are completely normal. What about this case? This was a patient who had just stressed imaging, and the nuclear tech calls you and asks you whether you want rest images. Here you can see a mild perfusion defect in the inferior wall, a common place where we associate with diaphragmatic attenuation. But what if I showed you a calcium score that showed tremendous amounts of calcium in the right coronary artery? I think we'd all agree this would be a patient that we would not want to take any chances, proceed with a rest image, and to see if possibly this perfusion defect we were seeing was due to ischemia or not. And this is really what the literature has shown, that when you have knowledge of the calcium score, it increases your interpretive certainty. In this first study on the left, 151 patients had interpretation of an MPI with and without the calcium score. And what they showed is when you added the calcium score, you significantly decreased the equivocal studies and increased the normal or ischemic studies. So you were much more confident in your interpretation. Similarly, in another group of patients who had stress imaging, and then data was interpreted in a stepwise fashion with calcium score being added last in order to determine the need for a rest MPI, they also again found that without the calcium scoring, you were more likely to obtain a rest study. Whereas once you added the addition of the calcium score, it decreased the need for a rest study by almost 64%, again here within that borderline or equivocal group. So here's another case to kind of drive home the point. Here's a patient with kind of a fixed defect on the inferior wall between stress and rest images, and the prone images in the middle are completely normal. Ejection fraction you can see is normal. So by perfusion imaging, this was a normal study. However, if you look at the stress EKG, this patient exercised, you can see that the patient had 2 millimeter ST depressions and actually had symptoms at peak exercise. In addition, when the patient underwent a coronary artery calcium score, you can see the arteries were chock full of calcium, and here the score was actually quantitated to 1800. So, we felt very uncomfortable calling this study normal with the EKG changes, the incidence of chest pain with exercise, plus the evidence of severe atherosclerosis within the coronary arteries. We pushed for further imaging with a coronary angiogram, And sure enough, the patient had triple vessel disease, and the nuclear perfusion images were a false negative, most likely due to balanced ischemia. So then, what is this subcoronary atherosclerosis actually mean? So here are two patients, patient number 1 and patient number 2. As you can see, both of them have perfectly normal perfusion studies. However, patient number 1 has no demonstrable evidence of coronary atherosclerosis, and patient number 2 has pretty significant coronary atherosclerosis in the left system. So the question I have for you are these the same patients, and will they have the same prognosis? Now, before we answer that question, I just want you to know that finding atherosclerosis is very common. This was a 20-study meta-analysis in patients who had completely normal perfusion scans, and the incidence of finding a calcium score greater than 0 was 72%. And what equally shocking was if you looked at these normal studies and looked at the incidence of calcium score greater than 400 or a severe coronary artery calcium score, 25% of these patients had it. So it's not unusual to have a completely normal SPECT study but have evidence of atherosclerosis. So what does this all mean for the patient? Well, we tried to answer this in our own institution. We took 1,100 generally asymptomatic patients who had both a calcium score and SPECT and were followed for approximately 7 years for major adverse cardiovascular events. And what you can see is, what has previously been shown in the data, that as your perfusion defect size increases on SPECT, so does your incidence of cardiovascular events. Similarly, as your calcium score increases, also you have a proportional increase in cardiovascular events. So, this was nothing new and had already been seen. But what we tried to do was explore the interaction or the interplay between calcium scoring and perfusion imaging. So we looked at, in this patient population, what is the prevalence of an abnormal SPECT exam in relation to their calcium score. And you can see here that as your calcium score increases, your risk of a perfusion abnormality proportionately increases, to the point where those with a calcium score greater than 400 had a 30% chance of having an abnormal nuclear study. Similarly, if you had a calcium score in this study less than 10, it was very unlikely that you were going to find a patient with an abnormal study. And in this particular study, I can tell you all these patients were a false positive result. This has also been previously shown in the literature, and this is just 4 studies that, again, here with pooled analysis shows you a calcium score than 400. Here in this pooled analysis, almost 26% had an abnormal myocardial perfusion image, whereas those with a calcium score is less than 100, it's very unusual. So did this study add new to the literature? So first is looking at the relationship of cardiac events based on perfusion findings and coronary artery calcium scoring. And you can see from this top left graph that as your calcium score increases, again, your risk annual event rate proportionately increases. But what was interesting to see is that at the moderate or severe degrees of coronary calcification, those patients who had an abnormal SPECT had a much higher event rate than those patients who had a normal SPECT. So that was one important finding. Another important finding was that if you just looked at those patients who had a perfectly normal a nuclear result, and I'm showing you the Kaplan-Meier curves here in the bottom left portion of the screen, you can see very nicely that for about 2 to 3 years, most patients do well. And this is really the warranty period of a normal nuclear myocardial perfusion study, where it can range from about 2 to 3 years. But then after that, you can see that the curves start diverging, all in relation to what the patient's calcium score is. So what this tells us is that your short-term risk, is dictated by your nuclear myocardial perfusion study, whereas your long-term risk is dictated by the total amount of atherosclerosis that are present in your coronary arteries, as indicated by your coronary artery calcium score. And this study went on to show that when it comes to, diagnosing cardiac events, by adding calcium score to nuclear imaging, had the highest accuracy when by global chi-squared statistics. So what about a cardiovascular PET? As you know, from this study also done by Dr. Malla at our institution, it can show you very nicely, as we've talked about before in the top left screen, that as your calcium score increases, your risk increases. Also, similar to what was shown previously in the literature, that those patients who had an myocardial flow reserve less than 2 did worse than those who had a normal MFR greater than 2. But what this study uniquely showed was that if you were to look at the relationship of calcium scoring, MFR, and annualized cardiac events, you can very nicely see that cardiovascular events increase as calcium scores increase, and that no matter what the calcium score is, if your MFR is also less than 2, you have a much greater degree of MACE compared to patients with the same calcium but an MFR that was within the normal range. Again, so they're suggesting that there definitely can be further risk stratification performed by the addition of myocardial flow reserve. Now, these aren't the only studies. There's a lot of studies in the literature and that have looked at the ability of hybrid imaging for diagnosis and prognosis. So here's another case I wanted to, now that we have this information, this was a 63-year-old. You can see here there's kind of a fixed perfusion defect in the inferior wall between the stress and rest images, which completely normalizes with prone imaging. Now, if you just had only this data, I would ask you, how would you treat this patient? Now, while you ponder that, also consider if I went on then and showed you his calcium score, and in this particular case, the calcium score is at least moderate with a score of 313. Now you know the patient may be at a small short-term risk, but definitely at increased long-term risk. Now how would you treat your patient differently? And I really hope, you would, between the two answers, I really hope with the addition of the calcium score, you would do something different. And why is that? And the reason is very simple. Prevention is better than cure. With coronary artery calcium scoring, we have the chance to identify subclinical disease, and we have the opportunity then to institute risk factor modification and pharmacotherapy before disease gets more advanced and these patients develop adverse cardiovascular events. So most of the guidelines, here's a summary slide of that, and you can see right in the middle there that will recommend for those patients with a calcium score greater than 100 that you consider statin therapy. Whereas if your calcium score is normal at 0, this is a patient who's at very low risk, and you can consider withholding treatment and repeating anatomical imaging between 3 to 5 years to see if they've converted and need statin at that time. But if your calcium score is more than 100, most all guidelines recommend the addition of a statin. Now, when you look at studies to see the performance within physicians, this was a study of 6 studies. You can see that with the knowledge of a calcium score, physicians were initiating aspirin, initiating lipid-lowering therapies, initiating blood pressure control, and patients were exercising more and changing their diets. So knowledge of a calcium score does have an impact on the physician as well as the patient. This was further seen in the Eisner study, which was a randomized trial of patients who had risk factor counseling with and without a calcium score, and they nicely showed that in those patients who had the calcium score at 4 years, they had lower cholesterols, better weight, and lower blood pressure than those patients who went simply counseling based on risk factors. So knowledge of a calcium score really changes the behavior of the physician and the patient. And we will see in the future that calcium scoring may be used to help us identify the highest risk patient population who would benefit from newer therapies which may be more costly. So in the end, the question is, well, are we going to save lives? And though we don't have outcomes data yet, there are about 5 clinical trials that are actively going to be answering this question. They're listed here on the screen, so stay tuned. We will have an answer shortly. But if some of these registry data suggest, hopefully we'll see a mortality benefit. In the Walter Reed data, which was a retrospective study, those patients who had a positive calcium score and were treated with statins had a survival benefit compared to those who weren't. And in 4 randomized clinical trials of chest pain, those who had anatomical imaging and were initiated on medical therapy early demonstrated a 31% reduction in non-fatal MIs. So, we hope to see benefit in those trials. So in summary, I hope I've shown you that, the old way of doing things is ischemia and no ischemia. We should get away from this. We really should move to, where we perform atherosclerotic imaging with our functional studies and report that the patient has no ischemia, no atherosclerosis, no ischemia positive atherosclerosis, or ischemia plus or minus atherosclerosis. So thank you for allowing me to speak to you today. The hybrid imaging guidelines mentioned on the right can be a further resource if you'd like to read more about this. I'm approaching the end of my time, and I'll leave the summary slide open so you can review what we have gone over. I'd like to again thank Dr. Noman and wish everybody Assalamu alaikum. And I apologize that I was not able to be with you.
An immensely interesting talk that has elaborated the added value of calcium scoring to perfusion imaging. Sir, your presence was deeply missed too. Our last speaker is Dr. Arif Sheikh, and he will be discussing some very interesting cases with us. He is the medical director of Catering Network Radiologists Incorporated. He is the director of Targeted Radionuclide Therapy and Cardiovascular Nuclear Imaging. He leads multidisciplinary thyroid and endocrine tumor boards and runs a targeted radionuclide therapy clinic. He has extensive teaching experience in multiple specialties: nuclear medicine, radiology, cardiology, radiation oncology, general internal medicine. He is radiology quality assurance officer for peer review activities. I'm thrilled to present our distinguished nuclear cardiologist, Dr. Sheikh, in physical appearance.
Shukriya. Good morning. It's great to see everybody here Sunday morning. Let's see, I am not getting I'm seeing myself. No slides. Oh, there we go. Thank you. So the previous 2 talks have been A, more scientifically based, B, have talked about incrementally adding on calcium scoring or looking for calcium atherosclerosis on scans. With the advent of cardiac PET, now we can do myocardial blood flow. And the issue with blood flow, that we talk about, what's been mentioned is that we can potentially find additional coronary disease. And again, I'm currently at a community hospital. We're doing cardiac PET. So we're not at an academic center. But we've really been blown away that myocardial blood flow, if you start really looking at it carefully, it is like reading an entirely different scan. So aside from what the two speakers have mentioned, I will show you what potential impact myocardial blood flow really has. So again, this is more case-based review, so I'm going to be light on the science. I'm not also, I want to try to make this interactive. Okay, so everybody please raise your hands or whatever, or maybe I'll throw out a question to you. And I just want to show you the approaches in interpretation. It's not to show that, you know, you should use this cutoff or that cutoff, but that being said, so what do we want to do cardiac PET? I mean, not going to the appropriate use criteria, but generally, why do you want to do it? And just ask somebody. They'll say, well, we want improved accuracy, sensitivity, specificity. That's appropriate. Prognostic significance, yes. An enhanced understanding of cardiovascular status, fine. Inappropriate. One of the cardiologists wanted to read cardiac PET, and he started reading it. And then when he started reading it, I asked him, why, you know, and then he started like, we're getting all these false negative cath, you know, or false positive PETs because we get negative caths. So why do you want to do it? Why are you doing PET? Well, I want to know which patients to cath. As a wrong answer. Okay? You have to understand what's going on and cath, how cath fits into that. It's also not a one-stop shop that I find everything about the patient. I don't need to do anything else in terms of imaging. Wrong answer. Okay? It's an entirely new understanding of what we are going to do with the patient. Okay, so what do we PET? This should say it all. This is a great looking scan in a patient whose BMI is 70, right? I mean, with SPECT, this is, you know, anybody's guess what that's going to look like. But that's what we start off by doing, and that's why PET, just that picture speaks a million words. I'm going to give you a brief primer on how to read PET studies. Again, whether it's PET or SPECT, what do? You evaluate the splash images, you look at the gated images, that's fine. The previous speakers have talked about looking at the CT attenuation correction. Now, the thing is, you notice all speakers will talk about using, let's say the formal calcium score was this. In this, we don't do formal calcium scores. You know, we say mild, moderate, severe, and there is actually a paper out there, which I haven't showed that if you do a qualitative assessment, you can get into the similar ballpark of getting a formal calcium score. So you don't actually need a formal calcium score, but you do need to go over the CT images to get an assessment of it's mild, moderate, or severe. The other things that we look for is something called splenic switch-off. Now, we do that with regadenoson. We're doing our stress tests with regadenoson. I understand many of you are actually doing adenosine stress testing. But what happens is, between rest to stress, you actually see a relatively decreased perfusion in the spleen, which is a good indicator that the regadenoson actually worked, because actually it turns out vasodilators may not work in some patients, and that I'll bring up an issue. So there are other cardiac findings, and then you do ancillary findings too. So if you look through the ASNIC guidelines, there is actually a paper, it's a pretty thick paper, of what to look for in the hybrid part of the imaging. I think it's an overkill, because if you look for all that and put it, your CT report's going to be longer than your cardiac part. So, but, you know, point being taken, I show it to my cardiologist, you want to read hybrid? This is what you have to do to provide standard of care. A lot of them back off immediately. Okay, so old cases, again, IQ SPECT is a Siemens cardiac-specific SPECT CT, okay? It's a cardiac-specific SPECT CT. So this patient had a cardiac-specific SPECT CT, non-attenuation-corrected images. Images look relatively fine. Maybe a little bit of a, you know, apical defect here, very, very slight. Most of us would probably ignore it. Now go to the attenuation correction images, which are the real images, right? And all of a sudden, oh, okay, wait a second, that defect becomes a little bit more, which is unusual. Usually it's the defect that should go away. It shouldn't come in with the, and you can see actually the anterior images too, there's sort of starting to become this sort of anterior wall ischemia. So what's really going on here, okay? So we took the patient to PET. So again, this is SPECT CT. It's unfair to compare PET versus poor old SPECT, okay? So we're going to compare SPECT CT to PET CT. Sorry, this went the wrong way. Where'd it go? Okay, so this is the, yes, rubidium images where you can see that that defect actually was there. It's a true defect, okay? And it's actually much more severe than stated in the SPECT CT images, okay? So why is this superior? Because part of it is, well, you get better attenuation correction, all that stuff. But remember, rubidium is a better physiologic tracer than sestimib itself. So you're going to improve your sensitivity that way. Again, another image where you see non-attenuation corrected images, you have a little bit of a reversible defect in the inferior wall. You do the standard CT attenuation correction, and that defect now all of a sudden switches to the anterolateral wall. Okay, so now you've got a reversible defect. Okay, what's going on here? So let's do a PET, and this turned out to be all artifact. The PET's absolutely completely normal. Okay, so even beyond SPECT CT, cardiac-specific SPECT CT, not just that. This camera is designed to be cardiac-specific SPECT CT, or it's actually a collimator, but PET improved that picture. Okay, so then we get to myocardial quantitative analysis. We look at the global picture, the segmental picture. We want to look at the absolute stress and flows. It's not sufficient to just look at the coronary flow reserves. You have to look at there's something called the flow gradient, which you have to look at what happens to the flow from the base to apex, because the perfusion sort of falls off, okay? Near the apex, it's a watershed area. That's the most hypoperfused area, and that has certain clinical implications, but you got to look for that. Something called flow capacity, again, there's a lot of controversy around that. A lot of people don't feel it's necessarily useful to report or look at that. I think it's a good way to learn about things, especially when you get starting off. Now, some simple parameters we use, CFR above 2 is relatively normal. It is age dependent. You have to be a little careful about that. Somebody who's 42 has a CFR of 2, you have to really think, is that really normal or not? The absolute stress flows also should be above 1.8. Idea, okay? So absolute rest flows generally are sitting around 1 or less. There's implications about that. You do a rate pressure product correction. I won't get into that today. I think there's enough other cases to cover. So what is it basically? You get serial images, or actually in list mode, you get continuous imaging in PET. You establish a blood pool and myocardium based on various compartment models. You can come up with blood flow equations. Okay, so I'm going to take some images from the literature and sort of combine our cases that we did in the community setting. So this is just an example of a normal study. So again, as the speakers pointed out, normal perfusion, negative CT for after cardiac disease, stress flows, nice, okay, all above 1.8, the very nice stress, reserve, very good. Rest is a little okay. I mean, it's in the right range. So we're good. So this is a normal study, okay? Okay, this is what I meant by splenic switch off. Again, this is just a patient. We got a random patient. You see there's a little bit more uptake in the spleen here at rest. At stress, that falls off, okay? So that's a good indication that the regadenoson actually worked. Okay, so how about this case? Normal perfusion, heavy coronary calcifications, okay? And then you see stress flows should be about 1.8. They're all down. They're severely down. Absolute flows. Reserve, also down. Should be 2 or above. They're down across the board. So again, this is from the literature. Patient had 3-vessel disease, went on to have intervention. From our side, okay, 76-year-old male. This is the easy part. Anyone want to throw out an answer what we're looking at? This is actually a SPECT part, okay? This is prone stress imaging, and then the standard supine stress and rest. Okay, so you see this inferior wall defect. And on prone imaging, that inferior wall defect doesn't go away. Now, on the rest images, that shifts a little bit. So you might think, okay, there's a little bit of ischemia, and maybe a little bit of diaphragmatic attenuation artifact because the fixed portion doesn't really match up. But that's pretty severe. You're not going to really go away believing that that is actually just a normal inferior wall myocardium. So you would think it's a fixed defect, and it's maybe peri-infarct ischemia, that kind of stuff. This is SPECT, not SPECT CT. Okay? And on PET, number one thing to note, inferior wall completely normalizes. Okay? So, and that defect stays. So now this is pretty severe ischemia. All right? So already PET has shown we've got severe ischemia. Inferior wall, ordinarily you would think, okay, we're going to find disease in the RCA and that's it. But now what do we see is, again, stress really bad across the board, okay? Reserves, actually reserve in the LAD is mild to moderately decreased, mild to moderate circ. RCA is decreased, no surprise, no brainer. Okay, this is the global CFR, okay? So if, you know, when people say CFR is 1.5, you realize this is not telling you the picture. You're missing all this, okay? So you have to go through these numbers. And if you're going to start paying attention to the numbers, now look at the polar plots, see what's going on. Look at the gradient, not much of a gradient there. It should be high to low, but not hair. See that? So when you start taking time to look at this stuff, you're going to spend as much and maybe even more time than you do looking at your images, because you're going to have to go back and think, okay, this, what did the image show? What did I say? What's going on here? You know? So this is really important, and the EF kind of dropped. Now, the literature suggests you should have a rise in EF. I'm a little lukewarm about that myself for various reasons. But, you know, but what basically this says is that you should look for multivessel disease when you go to the cath lab. Okay, so the patient had moderate severe size, severe mid-inferior wall ischemia. There's LV dilation. At rest and stress, it wasn't TID. Inferior wall ischemia was fixed, and cath showed, of course, you know, a high-grade stenosis, RCA, but the LAD and stroke were normal. Okay, so you've got bad flow globally. What does that mean? You got bad flow globally, but your cath was normal in the other two territories. Anyone want to hazard a guess? Quick guess? Exactly. You have a disease with global microvascular disease. Okay? This part, this global microvascular disease does not happen without the flow component. And again, so you've got perfusion, you've got atherosclerosis on CT, and now you're adding this component to the patient's thing. So that's where myocardial blood flow comes in, and very handy in terms of the patient. Okay, just another case where a patient had a stress test, and the stress, poor numbers, the images look otherwise fine, reserves pretty bad, okay? So they're like, okay, so what's the differential for this? What's the differential for this kind of, like everything's bad? Stress, reserve, three things. I'm sorry? Vasodilation. Correct. So just if you didn't hear that, is vasodilator failure, microvascular disease, or multivessel disease. Okay, those are your big three. But you can't tell based on this. Okay, so they said, okay, this could be vasodilator failure. Let's repeat the study, and sure enough, those numbers bump. Okay, they're still not normal, but the numbers do bump up, and they get better. Whoops, I'm sorry, this thing. Wow, this jumped a lot of things. Okay, so it got better. The numbers got better. Certainly the RCA is not an issue, but the LAD circ, and so again, suggestion that there may be, I don't know from the journal if they actually cath this patient or not. However, our case is, again, you see a relatively normal looking study. You see there's sort of this anterior wall stuff, but that's on the rest images. They look otherwise fairly good. See LV, a little bit of an LV dilation, baseline. Coronary calcifications, not much at all. Just a little fleck, okay? But across the board, Stresses don't look good. Rest, reserve, so on, not much. Splenic switch off? No splenic switch off, okay? So that's an indication to me, oh, this is probably vasodilator failure. And by the way, you have no way of knowing that on SPECT. So it's estimated about 10% of patients don't have a vasodilator failure. That is a large number if you think of the number of patients you're doing. So stress is better in rest perfusion. So we said it's a vasodilator failure. Would you like to repeat this? Like, no, we're just taking the patient to cathed them, 100% CTO at ostium, but the patient had collaterals. LC, circ and RCA was normal. They did not intervene, okay? So there is disease, but again, it's a regadenoson failure. Okay, 50-year-old male had a previous calcium score of 589, hyperlipidemia, mother with cabbage in her 50s, having chest pain, relatively normal study, agreed? Relatively bad numbers across, it's a relatively normal study, actually, but if you look carefully, there's a little bit of a defect in the anterior and inferior wall. And that seems to be a little reversible. And you come down here, and it almost looks like it gets brighter in the septal region. So it's like, okay, well, maybe there's something there, maybe not, okay? And then we look at the numbers. Stress, all above, more or less above 1.8. It's mildly decreased in the RCA, but your reserve is very good, okay, across the board. So actually, and EF jumped up nicely. Again, look at the pleural plots, okay? There seems to be a little bit in RCA, there's a little bit of an issue in terms of the gradient, but the gradients in the other areas look very well. And in fact, the reserve in that septal wall seemed to be even better. So again, putting it all together, and oh, by the way, there are coronary calcifications here, and it's actually fairly severe because it's a multi-vessel disease, LAD, RCA, circ, okay? So it's a relatively normal scan. It was felt that, okay, that was probably a little bit of a motion artifact. We didn't really pick it up on the sinograms and stuff like that. By the way, the techs really should be watching and monitoring the patient while the patient's in the PET scanner, because you could have motion, not necessarily motion that way, but funny breathing or things like that, which could give you different motion issues. You know, the person is getting vasodilator in the PET scanner. There is the issue of claustrophobia, right? So the patient may be a little bit more anxious and things like that. So they have to be watched and monitored really carefully. So again, possible motion artifact. You could argue there's a little bit of mild endothelial dysfunction, circ and RCA territories, but really no ischemia. Okay, so we have, how do I say endothelial dysfunction without ischemia? Is because your reserve is fine, right? So the reserve says there's no ischemia there. But your flow, your absolute flow, isn't quite normal. Okay, so you don't have good flow in there, but the vascular bed can compensate. So here, the myocardial blood flow actually help us determine that, yeah, this is probably an artifact that we're looking at. Okay, so again, in another small way, an MBF helps. Again, from the literature, you see inferior wall defect, reversible defect, ischemia. Stress is bad across the board. Reserves are pretty good, okay? You get, again, I'm deliberately ignoring the global number. The global number would say, this is, if you do the CF, that's what my cardiology colleagues started doing when they read PET. They say, oh, CFR was 2. It's like, no, you can't do that. It's a global number. There's a certain prognostic significance for the global number, but you have to go down into the depths of what you're looking at. Okay, so the point being is that even though the global number is down, it's, you have to kind of look at the individual regions. So our case is similar in the sense that you have an anterior wall defect, reversible defect, you can see it. It's a patient with a history of cabbage. You may recognize that kind of defect. It's very selective in the anterior wall, but it's clearly there, okay? And then you look at it, heavy coronary calcifications with cabbage-related changes. You've got other atherosclerosis. You actually also have calcified nodes there. Look at the polar plot. You've got decent gradients here. Maybe not so much in the LAD and RC, LAD and circ territories. Sure enough, if you look at the stresses, they're kind of down in the LAD territory, but the other areas are normal. Okay, so even if you just, hair reserve is 3, you could walk away as like, oh, patient's normal. Actually, the cardiologist who read this came to me, he's like, I don't understand. CFR is 3, and yet I've got that clearly ischemic defect. I was like, come on. You know, you can't be serious. You have to, but if you look at the reserve of the territory, those are normal too. Your tip-off is really just this number right here and your polar plots. Okay? So again, when you're looking at flow reserve, don't just look at, just take a number and run with it. So we see that there's actually a small defect anterior wall, and there's something moderately severe mid-distal peri-infarct ischemia. There's also small mild basal septal wall ischemia. I didn't really show that, which was, if you look back here, there's a little bit of reversibility. Okay. So I said, look, at the end of the day, this is not LAD, it's not a big thing going on. There's probably some septal perforators and things like that, and at risk, and the CFRs are pretty normal, so your risk stratification is pretty good. So again, hair CFRs are pseudo-normal, okay, if you just kind of look at numbers. I tell my residents, anyone who walks through, I said, you know, nuclear medicine, we generate a lot of numbers. Ejection fractions and, you know, renal function, split renal functions and all that stuff. I said they're all nonsensical. They're all nonsensical unless you can put it into the proper context of what you're doing. So again, CFRs are pseudo-normal, but they are focally decreased in areas of defect. So again, so there's likely some sort of septal perforator and stuff. At the end of the day, decide not to do anything with the patient. And again, this sort of highlights this from the literature where all those numbers are normal, but only these numbers in here are abnormal. And if you're not paying attention, because this is all above 1.8, except there's a little bit of LAD thing here, you know, you could totally miss it. And it would, or rather, it may not make sense. It may not make sense to you. So it's like, how can the CFR be normal? You know, because the clinician may ask you that. In fact, cardiologists are not reading petrovascular. It's normal. What are you talking about? You know, so. Okay, 81-year-old male, we see that there's a little bit of TID. I think this is the case. And in fact, if you look at the blood pool at rest, there's a little bit of leftover. At stress, the blood pool goes away. Okay. All right, so heavy coronary calcifications, has LVH, has stress is all down, reserves are good, but the stresses are down, okay? And you look at the polar plots, yeah, there is a sort of gradients there. The gradients are there, but it is globally down. EF is poor, okay? So 14 to 23%. It's went up from 14 to 23%, but obviously has a cardiomyopathy underneath. But the reserves are good. So findings, no epicardial or microvascular ischemia or infarct. Because why did I say no ischemia? There isn't anything here. The flow is bad. That's not ischemic. That is endothelial dysfunction. Dilated LV, you have heart failure with reduced ejection fraction, severe coronary calcifications, there's microvascular disease, endothelial dysfunction. CACS just showed a distal OM 90%, okay? LAD 75%, other small non-critical lesions. They decided to do just medical management, okay? So despite everything, you know, you see some issues, but it's not there. So again, non-critical coronary disease, microvascular dysfunction with dilated cardiomyopathy. And there was a question, actually, if the patient had had a baseline dilated cardiomyopathy to begin with, on which there is superimposed coronary artery disease, okay? Again, that's the kind of thinking that we don't really think about in standard SPECT imaging. This is from the literature again, it shows you a big infarct, maybe a little bit of infarct ischemia. The reserve in the LAD territory is not bad, it's down. But the point of this case is, what is the reserve actually? It's literally the ratio of this number to that number. That's it. That's your reserve. So if you got bad perfusion, it's kind of like 0 divided by 0, okay? And, you know, well, 0 by, it's not going to be it's not going to be 0. It's going to be a number. And then you say, oh, that's not so bad. Well, no, it is bad because you just don't have perfusion. So you don't believe that LAD number. This is where the polar plots may help you, where you start breaking the myocardium into different parts and looking at it. But again, this is, you know, don't just believe the numbers. Look at your images first and then go to the numbers. Your numbers should help you interpret the images, not the other way around. 94-year-old guy with known dilated cardiomyopathy in this case. And again, relatively normal perfusion. And by the way, I do call this a normal scan because that's within the limits of testing. It is a normal scan. You can't deny that. You know, like if something else is abnormal, like because the stress testing for it, it's a normal scan, but abnormal stress testing, recommend whatever, catheterization or whatever else. But this, I can't deny the scan is not normal. So this is the black and white version. So this actually, we do see a little bit of an anterior wall defect here. Is very, very, very slight. It's the black and white version. This is the color version of it. You can see a little bit reversibly. It seems very, very mild. And the LV is dilated. We see heavy coronary calcifications, okay? Again, stresses are down, not terrible, but down, mild in the RCA, and understandably, LAD region's a little bit down, flow, reserve, borderline low, you know, it's just a shade below 2.0, and RCA is 2, so we're good. EF is a little bit down, 37 and 44, not surprising because the patient has an underlying dilated cardiomyopathy. Okay, so what does that mean? Large anterolateral wall ischemia, dilated LV, reduced stress flows, CFRs are mildly decreased. CACS showed just 50% in the LAD, so not the significant regions. So LV function is disproportionate to the level of ischemic disease. Excuse me. So again, non-ischemic dilated cardiomyopathy with mildly obstructive ischemic disease. Okay, and then there's endothelial dysfunction. Some level of endothelial dysfunction because, again, the degree, we're not really seeing that much ischemia here. It's mild to moderately decreased, but, you know, so they've got several things going on here. It's not just ischemia or not ischemia. Another one, this patient has moderate coronary calcifications on the CT, not really seeing that much, and perfusion, same thing. Everything looks down. It's not normal at least. Gradient is okay. Went on to have a cath. The EF didn't rise that much, but LAD was patent. There was a little bit of stenosis in a D1 branch. RCA stenosis, not much going on at all on the cath, okay? So the patient did go on to have a cath, and so this is predominantly microvascular disease with significant, there is, you know, stenosis in distal small vessels. So it's there, but it's low consequential. They didn't intervene. They felt medical management would be the best. Low consequence obstructive disease. So we did, but, you know, bad prognostic signs. TID, which would suggest endothelial, subendocardial ischemia, possible small apical ischemia as well, and overall prognosis, despite everything, is decreased. Okay, and there's a common thing that, you know, how does CFR relate to FFR? They're not the same things, and in fact, some studies have looked at it that overall PET CFR may have better diagnostic value compared to even CT-FFR. 63-year-old male with cardiomyopathy, lots of problems. Calcium score not that bad. You see a lateral wall ischemia, sort of anterolateral, lateral, comes to inferior lateral wall ischemia. Circ is bad, not surprisingly. Flows, reserve, not great. Reserves are down all across the board. EF is bad. In fact, it went down, okay? So here, in this case, severe 90% stenosis of proximal OM1. They stented it successfully. Normal LV function, EF was fine. But again, that was the only area that stented. They didn't see anything else in other territories, even though those were down, right? So this is moderate severe ischemia, basal midventrolateral, drop in EF, globally decreased myocardial blood flow. So this is obstructive CAD, again, with diffuse microvascular ischemia, okay? So again, we're adding things, we're beginning to understand things and add to the management of patients far, far more than just looking at the images alone. And there have been guidelines out in the, for quite a while in terms of how to approach patients when, you know, not just with what the images look like, but how your flow reserves look like, and then going down that pathway. And now, as was mentioned, fluoroperidase has just been approved. O15 is also in the works, will be only at very specific sites. But again, as I mentioned, you know, you have sestamimide and tetraphosphamide here in terms of your blood flow response, and rubidium is better than those, so you'll get better evaluation, but you get even better evaluation of fluoroperidase and O15, which are near unity or almost what the ideal perfect tracers. So, you know, we might be able to even pick up even more disease. So, in summary, PET images improve appropriate identification of epicardial disease, okay? The MBF numerical analysis should be evaluated as much or more diligently as the imaging component. So you have to really, really break it down and go into what's going on. Cath may still be needed, despite this cardiology, oh, I don't know a cath. No, 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 no. Why? Catheterization of abnormalities or normal areas. Because what you want to do is you want to characterize what you're looking at. So I told everyone you need to think of cath as an added tool. You have to get away from this concept of false positive, false negative. It was abnormal to, you know, the flow was abnormal. It's an abnormal study. I don't care what the cath shows. The cath just tells me, is it obstructive or non-obstructive? Those are the things that's adding, okay? So PET with myocardial blood flow helps find and further characterize the heart disease. You know, could it be non-ischemic dilated cardiomyopathy or not? Add that in. And again, it's part of a multimodality imaging approach. So some people, I say, you know, okay, coronaries look clean, you know what, go ahead and get a coronary CTA as a follow-up. And we haven't gone back and seen, you know, how many we've looked at our patients who got cath, we haven't seen how many have followed up and got coronary CTAs. But really, we can't take this modality in isolation. It has to be as a multimodality approach, and which cath is a part of. We have to get away from the paradigm that this is just a gatekeeper to cath. It is not. It is a gatekeeper, but that's not the only reason. And sometimes we need the cath to further define what's going on. And with that, I believe we can go to the Q&A session.
Yes.
Thank you. Appreciate it.
A big round of applause for our eminent speaker, Dr. Sheikh. It was indeed a pleasure to learn from the erudite of our trade, Dr. Sheikh. Are there any questions in the audience?
Sir, is there any difference in pattern of calcification in abnormal myocardial perfusion imaging in coronary vessels, or only calcium score is the most important thing that we need to know?
It's a very good question. You know, sometimes you get this diffuse pattern, sometimes you get these flex patterns, and I'm not as well versed with the CT literature to say, you know, do they have different prognostic significance and things like that. But it's you have to step back and think of pathophysiology. The calcification of coronaries is a harbinger of what's going on physiologically. You know, it's sclerosis going on. So It is not, it is a marker. It has nothing to, well, it is not endothelial dysfunction per se. There's problems going on, and that alerts us to potential problems that may arise with the patient. But by itself, the calcium score is not the obstructive component. You know, we worry about the soft tissue plaques, right? So it's the soft tissue and the hard plaques closing in that cause it. So by themselves, they're not it. They're not the whole story. So they're not going to relate to perfusion directly, I do not believe. And, you know, same thing, you can do FFR and things like that in the cath lab. So just because I see, say, a big focal calcification in the proximal LAD doesn't mean I'm going to say, oh, I'm expecting to see a perfusion defect. I'm not surprised if there is one in the LAD, but I don't go in there expecting to see one. You know, I might see something in the RCA despite the LAD being the one that's calcified. So it's more of a biomarker than an actual definition of where the ischemia is taking place.
Thank you, sir. I have another question. That is there any difference in blood flow parameters between fluoroperidase and ammonia? Are they both comparable, or which one is accurate or more convenient?
Oh, so that's a very good question. So the issue is that, in theory, fluoroperidase, because of those flow characteristics, should give you even better definition of problems, ischemia, and stuff like that. The problem fluoroperidase is going to have is that you're going to have background activity. With rubidium, 72-second half-life, it's gone. By the time you're finished imaging the patient, it's gone. You're just waiting for the generator to regenerate, and then you can stress the patient right afterwards. There's no background activity. Ammonia, there is background activity, but if you choose to, you could wait it out in an hour and a half, 1 hour, 40 minutes. You're 10 half-lives out, you're done. Fluoroperidase, that's just not practical, right? So they're going to, since they just released it, they're going to work with the vendors to come up with some sort of official software which will subtract the background out and take that into account. So I don't know how well that's going to work out. That remains to be seen. They just approved it. That means they are going to market it probably sometime in 2025, and then distribution and all that stuff. And then that software has to come out before we can start relying on these flow reserves with fluoroperidase. And by the way, you cannot do flow reserves if you exercise the patient. That's a big drawback.
We will take our last question
Thank you,
from
sir.
Dr. Khalid.
A small comment actually. In fact, we are using myocardial perfusion scan excessively, but the reason is because of its negative predictive value. Once it is negative, I mean, probably cardiologists would be happy not to do anything more. But once it is positive, straightforwardly they will go for angiography. I don't think that they will ask for PET or something. Only then one question remains is viability if they are going to revascularization. So I don't feel that such an expensive test should be included in that scenario.
Again, that thinking goes into the sense that myocardial perfusion study is used as a gatekeeper. It is no longer a gatekeeper. It is now part and parcel evaluation of the patient. So we are now providing information in addition to cath. Not just like, oh, should they go to cath or not? Now cath will become, we've provided all this information, you're just going to go into cath just to sort of further define what's going on, and then maybe need to stent. Now some lesions will be very obvious. You see a problem, a defect, yeah, you know, you're going to need to stent. But that's exactly it. If you go there and start seeing multivessel disease, and then you're like, oh, it's really only the anterior wall, the other lesions, they don't look so bad, you know, maybe I don't need to stent, you know, that's where the blood flow comes in, that, yeah, you do need to stent. Now, for example, viability imaging, I'm pushing our cardiologists, and they're beginning to realize that because when they send for viability imaging, they send a patient just for viability. We do a rest perfusion and viability, okay? I just went back through it. And why do they do that? Because they say somebody shows up with a big dilated LV dysfunction, and there may even be a regional wall motion abnormality. And I tell them, look, you need to do stress-rest viability together. Because again, we want to really define what's going on. Because a lot of times when you think you've got viability, it's, you're not actually, we've actually looked at our database. About 25% of the patients who come in for viability imaging have a normal perfusion scan. They don't even have a defect to begin with. So that's quite a big number. So again, the point is that cath, you can't look at that as just, oh, we're going to decide whether or not we're going to cath the patient. The question is, we have this information about disease, and what more is cath going to let us know about the disease, and then we can decide at that time whether to intervene or not.
I have just a last question. How do you see the role of this flow assessment in patients in post-CABG patients as well as in the end-stage renal disease?
Yeah, that's a good question, because the flows are reduced in those patients. But again, when we talk about, overall flow, I mean, let's think about it. Why are those flows reduced?
Due to altered anatomy in post-CABG patients, and in end-stage renal disease, there is calcification of the arteries. So
there's calcification, but basically what is the flow telling you? That there's endothelial dysfunction.
Exactly. So is it reliable to do flows?
Yeah. I mean, every case I showed you had across the board abnormal function. So, I mean, is it reliable? Yes. But again, of course it's reliable, because number one, it's abnormal to begin with.
Exactly.
You've got a problem, okay? Now, is it changing and stuff like that? Is it going to add that particular value? Maybe not the same way, but you already have an abnormal myocardium to begin with. What you're looking at is just to see if there's epicardial disease, right? And then again, you have to go into the nitty-gritty of it. Look at all the numbers, look at your polar plots, look at your gradients. Those all have to kind of make sense, right? So obviously, if you just got a bad ventricle to begin with, bad myocardium and everything like that, and now you're like, well, is there additional ischemia or not? Well, you've already got microvascular ischemia, and so it's not the flow reserve, it's your splash images that are going to tell you whether there's ischemia or not, right? So all of those are additive to each other. So I think, yes, there is value of that, but we can't look at just, flow reserve is just a whole new piece of data that comes in that once you start diving into it, you realize a lot needs to be said. Yes, it's supportive, but don't just look at it that way. So if the flow reserve is abnormal, it's normal. It's abnormal. You've got a sick heart. But now let's still look at obstructive disease through the images.
Thank you so much, sir.
Thank you.
Now I would like to take comments from our co-chair, Dr. Iftikhar Alam.
Thank you. Well, it's the end of today's first session, and our three distinguished experts showed their experience in nuclear cardiology. Nuclear cardiology is being practiced in almost all centers of PAC, and in the first speech, Dr. Mullah beautifully described the shift of paradigm from cardiac SPECT to PET with newer agents, which definitely add in accuracy of diagnosis. He described the US guidelines in diagnosis for low to high risk patients. He also discussed the introduction of AI in attenuation correction and precision of diagnosis. He stressed on the role of PET-CT in non-atherosclerotic conditions like cardiac amyloidosis, endocarditis, aortitis, and myocarditis. The second talk of Dr. Faisal Nabi, he discussed added value of cardiac calcium scoring to perfusion imaging. He beautifully discussed the cases and showed how calcium scoring increases the interpretative certainty, and increase in calcium scoring and chances of ischemic findings in SPECT imaging. And plus the prognosis of cardiac ischemia in high calcium score cases. As he said, prevention is better, so he showed the role of calcium scoring in prevention of ischemic heart disease. In the third talk, Dr. Arif Sheikh, it was a case-based discussion, and he compared SPECT and PET-CT and improvement in diagnosis. He highlighted the edge of PET in quantification of cardiac parameters, and he beautifully correlated myocardial blood flow, calcium scoring, and wall motion abnormalities in his cases. And in short, all the talks increased our understanding in the nuclear cardiology, and it was a great discussion. Thank you.
Thank you so very much, sir. Now we would take comments from our chair, Dr. Javed Irfanullah.
Assalamu alaikum. Is that working? Yes, these were all wonderful talks, and I really appreciate the audiences over here. I think the nuclear cardiology has progressed a lot since we saw it in its beginning, from thallium, simple thallium, planar imaging to this level. There is always improvement, and we always think that this is the last, but it is never last. It will go on like the life is going on. So thank you very much for all of you listening. And my co-chairman has briefed the things, as he said that he will do the first job and I will do the final job of thanking you all and the speakers. I think this thing will go on forever. Thank you very much.
Thank you so very much, sir. Now I would like to invite President PSNM, Dr. Shazia Fatma, to give away the token of appreciation to the chair and co-chair. Our chair for the session, Dr. Javed Irfanullah. Thank you, sir. Now our co-chair, Dr. Iftikhar Alam. Last but not the least, myself. We are ready to start our next session. Please stay here.
Assalamu alaikum, ladies and gentlemen. I'll be the moderator for this session. I would like to call upon Chairperson Dr. Hafiz Khush Naseeb and Ms. Noreen Marwat to co-chair the session, to please come on the stage. Dr. Hafiz Khush Naseeb is Director, CINAR, Quetta Center. He's MSc Nuclear Medicine and is the recipient of Distinguished award from the Chairman PAC Distinguished Award. Ms. Noreen Marwat, she is also an excellent medical physicist working in Nuri, and she, on her part, has various accomplishments during her career. Our first speaker, so with the permission, should I start the session? Our first speaker is Dr. Humayun Bashir. He'll be delivering his talk, very interesting, on a very interesting topic, that's molecular bone imaging and the risk of fracture assessments. And he is working at the moment at the East Kent University Hospital NHS Foundation, and he's an honorary consultant at Shoghat Khanum Cancer Research Hospital. He is a renowned nuclear medicine physician having more than 23 years experience, fellow of College of Physicians and Surgeons Pakistan, Royal College of Physicians of London, and Edinburgh, European Board, Edinburgh, as well as European Board of Nuclear Medicine. So it's Dr. Humayun Bashir, it's over to you now for the talk.
Hello, Assalamu alaikum. Thank you very much, Dr. Ambreen, for the introduction. I hope you can all hear me. Okay. Well, today I'll be talking about molecular bone imaging for fracture risk assessment. To give you a bit of the background, sorry, the slide. Now, this discussion about bone metastasis, this goes way back. Dr. Stephen Paget recognized in 1889 that breast cancer had a predilection for metastasizing to the bone. This is one of the first papers published in Lancet back then. And then this theory of seed and soil was introduced. It was revisited in this paper, published around 2004. The idea is that emboli of the tumor and the fibrotic stuff around the tumors that actually leaves the primary site of the tumor and travels across the motorways of the body to the vessels into systemic circulation and then seeds into bones. So that's the idea behind this, how the bone metastasis develop. Of course, tumors themselves are very vascular structures, and there's a whole predilection for having this capacity to pick the emboli and then sort of carry them around the body. So when these emboli of the tumor, they go and settle into the bone, there's a receptive environment there. There are two mechanisms in bones, osteoclastic activity and osteoblastic activity, and there's a very, conducive molecular environment there, which results in these mechanism, and the tumor cells become part of that whole, what you call microscopic or molecular process, while there's formation of new bone through the osteoblastic pathway, and at the same time there's osteoclastic activity going on. Now the biochemical markers, they're different for both osteoclastic and osteoblastic bone turnover, and that actually results in metastasis.
Sir, excuse me, sorry for the interruption. We are not seeing your full slideshow right now. We're just seeing your PowerPoint screen.
Sorry, what can you not see?
We are not able to see your full slideshow. We are just seeing your slides and the PowerPoint editable screen. Are you using dual monitors?
No, I'm not using dual monitors. I'm trying to share the screen. Is it now? Yeah.
Okay, yeah, perfect.
Okay, sorry about that. Yeah, please. Sorry about that. Anyway, so the biochemical markers of bone turnover are released during this bone remodeling, osteoclastic as well as osteoblastic activity, and that develops into the different types of metastasis. Now, these mechanisms at play provide the therapeutic opportunities, interventions into osteoclastic or the osteoblastic activity, provide the therapeutic opportunity for us to strengthen the bone, while the metastases are there to actually weaken, and as a sequence of the whole process of the tumor spread. Now, with this background, there are these are two papers, one published in 2008 and the other published in 2018, 10 years apart, editorials by Dr. Alavi with some co-authors. And with the advent of FDG, like since early 70s, MDP is the tracer of bone imaging, better than any other imaging, very sensitive and able to identify the spectrum of disease in the bones. With FDG, this whole debate started that FDG is better than the bone tracer. So as a response to that, Dr. Alavi and his team wrote these two editorials trying to emphasize that it's not fair to compare an MDT tracer with FDG, because FDG is talking about metastasis in the marrow where the actual metastasis is, while the MDP is picking the secondary reaction to the metastatic lesion inside the bone. So we basically emphasize that we strongly advise that the concept of bone marrow instead of bone metastasis should be highlighted once you have FDG and more specific tracers in your hand. Now, going back again in history, this paper from 1917, the prognostic and therapeutic significance of skeletal metastasis in carcinoma of the breast. Now, Isaac Levine, in this paper, they actually identified that the mechanism of the development of growth of skeletal metastasis, and they sort of placed that at that time, the modality, the best modality of that time was the X-rays, and they emphasized the need of X-rays in breast cancer patients, sort of to look for bone metastasis. So this, doing this workup for skeletal metastasis started around early 20th century. This is a review published from 2020, which talks about the state-of-the-art imaging for diagnosis of the metastatic bone disease. And in this table, you can see, it talks about the X-ray CT, SPECT-CT, MR, PET-CT, and PET-MR, and every modality looks at different aspects. X-rays and CT look at the morphology, metabolism through radio tracers, marrow involvement, same radio tracers, while MRI is looking at the marrow, and the metabolism is looked at by, again, the radio tracers through hybrid imaging. Same paper, they have looked at various malignancies. You can see prostate, lung, bowel, bladder, and then breast, bowel, and lung in females, and the GU malignancies. And you can see that the marrow involvement is in all these metastases coming from all these different malignancies. While there can be some involvement of the bone, as we can see in the prostate gland, so the lesions are mixed, more mixed. The breast has also got mixed, but marrow is the consistent site of what we call bone metastasis. Now, with this background, there's a need to look for fracture risk assessment. Now, whenever in an oncology setting, it's a nightmare to know that the patient disease has spread to bones. Now, with that, while all the options to treat, systemic options to treat are there, there's a major risk that metastasis, if it is very extensive or at critical areas, it can actually lead into fractures. So we need to assess for fracture risk assessment. Overall, the disease survival is increasing with different treatments. Cancer patients, cancer survivors are living longer. So the importance of finding risk sites is also important in this scenario. There are various modalities to look at as we just saw. Cartography, there's the science of drawing maps. What we get from a bone scan or a whole body FDG PET-CT scan, a whole body bone scan is just to identify where the lesions are. So that's one thing where we have molecular imaging tools, SPECT as well as PET tracers. And the other thing is to assess for the fracture risk assessment. Now, for fracture risk evaluation, this is a burning issue, a paper review published in 2021. It basically, this biomechanics is involved, and in this graph, you can see that there's a linear relationship initially when there's, the bones are able to bear the brunt of the remodeling going in itself. Then it becomes very strainful, and then finally it fractures and breaks. So there's an elastic domain of that bearing the stress. Then there's a plastic which can lead to deformity, and you can see cortical loss, and then finally it has to break if left untreated. From this paper, two examples on the top, you got this sagittal and axial section through a myeloma lesion in the vertebral body. Myeloma, as we know, is predominantly and purely lytic, so you can see lytic lesions there at T8 and T9. In the second row, we have urothelial cancer, in which there's a predominantly lytic lesion at the baseline, which with treatment 2 months, 4 months shows a lot of sclerosis, while there was one part of this lesion which remained lytic, and then 6 months down the line, it became that lytic component which was not responding, while the sclerosis was response to treatment. The lytic component sort of predominates and then takes over the whole lesion, and this is progression of the bone metastasis after some partial treatment response. Again, the authors have highlighted, if you see in this dark curve, this blue line is the higher risk of fracture. Initially, there's anti-cancer drugs, which actually puts the whole body, the entire metabolic system into a sort of challenge, and the risk of fractures increases. Then there is healing of the bone, and then eventually when the cancer is in remission, there's condensation and there's the risk of fracture sort of decreases. And at the bottom, they've shown images that the patient has been treated with calcium, vitamin D, and the bone-targeted treatment options. The sclerotic response, as we saw in the previous lesion, and the sclerotic response actually shows the strengthening of the bone. And then if there's some disease left, that would be coming back as a destructive thing later on. Now, there are two risk scoring systems at the moment, primarily based on radiology. This blue box shows you the Maris scoring system for the long bones, and this green box shows you the spinal instability neoplastic score for the spine. There are various factors to it. Basically, they depend on the site of the lesion, the nature of the lesion, lytic or mixed or plastic, pain caused by that lesion, extent of the lesion, how much of the bone is involved. Alignment and collapse are more to do with the spinal scoring system. Eventually, the Maris scoring system, essentially for the long bones, categorizes into low fracture risk, borderline, or the impending fracture. Similarly, on the spinal system, there's stability, potentially unstable, and the unstable. So you can see, there has been effort to come up with a risk assessment for fracture. This is a paper from Hamza Murza, which looked at the various studies which have evaluated the spinal instability neoplastic score, and they concluded that although the relatively high reproducibility of the SINS among multiple medical specialties is encouraging, additional studies are needed to determine the validity of the SNIs with prospective studies. So the systems, what is available to clinicians and the imaging people is there, but it has its limitations. Metastasis happen, bone metastasis happen in all malignancies, so there's variation in the presentation and the lesion characterization. They have tried to come up with systems of score which can be applied to most, if not all. Now, in this paper, nice review article, Fracture Risk of Long Bone Metastasis, a review of the current and the new decision-making tools for prophylactic surgery. Nguyen and the team have looked at that there's a multifactorial problem, as we saw from the initial slide. A multidisciplinary approach is required. We have to come up with a system easy to input, limited in number and complexity, and cost-effective to score the risk of fracture in a bone metastasis. There are radiological features or imaging features, and of course, machine learning is or can become a crucial part of it. They actually compared the three available systems. One is the Maris scoring system, as I discussed, in the long bones, in which a score higher than 9 has got high sensitivity, but there is limited specificity with that. Then there is a axial scoring system on the CT, which 30 millimeter of cortical bone involvement, and then there is another scoring system in which the extent of the cortical involvement is used, which has got very high specificity. But these ACI and CCI are based on CT, and the Maris scoring system is based on X-rays. They further added to this evaluation FDG PET-CT. Here you can see at number 3, in which there are studies we have looked at the proximal fracture, femur fractures, and they found that the glycolytic volume could be a good predictor with relatively high specificity as compared to other scoring systems. In this table, you can see at top there's a mild scoring system, and then we have the CT rigidity assessment and CT finite element assessment. These are computational programs based on CT trying to evaluate the risk. This is a good pictorial. I couldn't get the images for these, but basically this also highlights that the mild scoring system based on X-rays has good sensitivity but poor specificity, while the CT rigidity and finite assessment with the computational programs have better reported specificity, but then they require specific training and computational tools to actually evaluate it. The simplest and the most commonly used mild score has a tendency to overpredict the fracture risk. So now, as we look forward, we just see the need for assessment for prophylactic fracture femur stabilization. The idea is that if we are able to effectively calculate the risk of fracture, we can intervene early, and that has got a better outcome as compared to fractures which actually happen, because then it has an impact on the quality of life and the outcome as well. They have the fracture assessment clinical decision making for patients with metastatic disease. Multiple papers established that there's survival advantage to prophylactic stabilization as compared to when pathological fractures actually happen and then they are taken care by the orthopods. Radiotherapy is used for metastatic bone disease. Again, in a bone at risk of fracture, radiation therapy used earlier has better outcome as compared to radiotherapy for pathological fracture once they have happened. Radiation therapy also reduces the pain caused by the bone metastasis in addition to avoiding the pathological fracture. In this paper, they have compared the outcomes of intermediate nailing between impending and completed fracture. They normalized most of the factors, and then they realized the conclusion was that patients with metastatic femoral tumors who underwent intermediate nailing in the impending fracture group had better post-operative survival, gait function, less blood loss, and shorter durations of surgery in hospital. So it's clearly that it's best to actually identify impending fractures and fix them early on. Here it needs to be highlighted that if with this risk, if they start over-treating fractures which are not at risk, that's also not a good idea, because the cancer patients have a higher risk of having post-op complications. So you don't want to treat bones or metastases which are essentially stable. So it's important to differentiate between the two. This is a pathological fracture healthcare resource utilized assessment across 8 European countries, and they say that one skeletal event or multiple events, again, it has an impact on the cost. The increased number and duration of inpatient stays for the pathological fracture of the long bones was more than fractures or problems with metastasis in other bones. So again, the weight-bearing areas, particularly the femur, which has got an impact on the quality of life more than other lesions, is important, and then it of course translates into healthcare resource utilization and costs. Now with this background, going back to this paper from Nguyen in which they looked at the mild score of 9 is with high sensitivity but poor specificity, what can we do? It's the time to think about SPECT-CT. Bone scintigraphy has changed with this SPECT-CT tool that we have in our hand. So based on this, we looked into literature. This is a pilot study which was done at Chicago Hanam Hospital, in which we used the SPECT-CT bone scintigraphy to come up with a modified model score. And at the bottom, you can see the two tables. Table 1 is about the conventional model scoring using the X-ray. Modified scores, we were able to add in this characterization of the lesion, where it was plastic, mixed, or lytic on X-ray, we could evaluate it better as plastic or predominantly avid lesion, mixed or predominantly lytic, based on the SPECT-CT. Additionally, we could look at the size XL-CT better than what we could see on a 2D X-ray, and we could also see other factors. And so this is the differentiating, the modification in the mild scoring system. So in this pilot, we saw that in the patients who are having a mild score of 8 on X-ray, it became sort of only 5 patients were left with score less than 7 on SPECT CT, while in patients greater than 9 at high risk of fracture, SPECT CT was able to identify more patients as compared to the X-ray. The area in the middle, the score, patients with score of 8 are the ones which are the tricky ones. And the score with 9, greater than 8 actually go for prophylactic fixation. The score with 7 can be observed conservatively, while the 8. So basically SPECT CT help shift the patients from the high risk into low risk. Here are a few examples here. The score 7 becoming 8. The images, I'm not sure whether reflecting that well, but in this image you can see that the lesion was predominantly lytic. From 9 it remains 9, and from this one 9 becomes 11. There's more lytic component. So essentially cortical lysis was noted in 8 by SPECT CT versus 2 by the X-ray. Additionally, SPECT CT parameters were circumferential involvement could be better evaluated, and X-osseous component could also be seen in 3% of the cases.
Dr. Hamayu, we are running short of time, so if you can just hurry up, please.
Yeah, I'll just a couple of slides now. I'll be quick. So this is a paper about the role of FDG PET CT in assessment of femoral pathological risk. And in this study, you'll know that look at the glycolytic component of a metastatic lesion in the femurs. And they basically said the quantitative measures of FDG avidity may help identify breast cancer patients. They came with a TLG cutoff of 81, which has got accuracy, sensitivity, and specificity around 83% to 80%. So basically, going back to the new tools of decision making about prophylactic surgery, I've shown you 2 papers, one with this from bone SPECT CT, modified mild scoring, and the other from the use of FDG PET CT. So these are the new tools. Now you can see that this paper from on SPECT CT was published in 2018. The FDG paper was published in 2017. This review was published in 2021. Now since this, like almost 5 years ago, these papers on SPECT CT and PET CT have been quoted in various review by the orthopedic teams that these are the new upcoming tools, but there haven't been many studies around these new ideas and new options. So some more data needs to be required, is required to actually verify these techniques for the utility. So in conclusion, we know that the global incidence rate of cancer is projected to increase. Newer therapies, there's better survival, which requires better prolonged, better quality of life. Prophylactic treatment of possible fracture risk, long bone weight-bearing fractures is important factor in quality of life, and we need some risk assessment tools. They are available in conventional nuclear medicine as well as PET CT, but more needs to be done. The nuclear medicine can offer these tools. Cartography, of course, mapping we can do with the whole body scan and FDG, but we need to get some more tools. CT is there. With hybrid imaging, we have the CT at our disposal to offer that sort of risk assessment. Thank you very much. I would like to conclude my talk. This is a picture from the recent E&M board exam faculty meeting in Hamburg. And I've put here this mid-winter meeting coming up with a November 6th abstract deadline. There's special incentives for research done in Pakistan to be presented at this meeting. And obviously, ACNM offers membership, free membership to residents, and more people from Pakistan should actually avail it. Thank you very much.
So, any 1 or 2 questions from the audience? Quick questions? Thank you, Dr. Humayun Bashir, for such an informative session. Our next talk is from our worthy and renowned consultant nuclear medicine physician with having more than 30 years experience. He has been serving as former DG NMO at the PAC, and he's currently working as consultant nuclear medicine at Inmol, Lahore. Dr. Ahmed Qureshi, so kindly please come on the stage. He'll be delivering his talk on response assessment in the solid tumors.
Assalamualaikum, dear colleagues. Chair, thank you for inviting me for the talk. I've got a very simple talk, whatever I've been listening since morning. So my talk is about the various criteria we use for the response assessment for solid tumors using PET-CT. Next, please. So our radiology colleagues, they have developed different criteria on which they can assess the various imaging modalities, like in the breast, colonography, hepatocellular carcinomas, etc., just to standardize the various reports they are making. And then in case of tumors, they have got RECIST criteria, which are there in use for radiology modalities only, in which complete response, partial, progressive disease, or stable disease are defined. Usually these are all measurable things on CT or MR, and here they are using sum of diameters, etc. For nuclear medicine people, this is not possible because what we are measuring is different. Here we are talking about PET criteria, which in metabolic response in case of FDG uptake. Sorry. Can I have another one? It's very weak. And complete metabolic response, partial metabolic response, progressive disease, or stable. So in our oncology setups, they need the help from our colleagues in nuclear medicine if they can give us the idea whether the patient is responding to the treatment or not. Way back 20, 25 years ago, SUV was the only modality, the quantification for us. And initial you have to move it. जब मैं कहूँगा आपको नहीं, ये एक्चुअली बहुत ही वीक है. So SUV was the only criteria in which whether it was malignancy or benignity of the lesion which was seen. And when we started PET back in 2010-11 in mole, the main question from our oncology setup was always whether this lesion is malignant or not. And 2.5 was the SUV criteria, which was a magical figure. And we always said that this is not a standardized uptake value, rather it should be called silly uptake value, because it's not cut off actually. And here, if you see the changes in FDG uptake in the scars or recurrence of the disease, then there was a considerable overlap. There was considerable overlap of the lesions in whether they are tumor itself or they are only non-remnant scars there. So comparison of RECIST and PERSIST criteria. It has been now known that the concordance of responses between RECIST is not excellent, and PERSIST is maybe having much more advantage as compared to RECIST or radiological. My presentation now, I will try to cover as much as possible if Dr. Ambreen allows. So I will try to cover Hopkins criteria, Duval criteria, Lyric criteria, and impetus criteria. Most important and most used is the Duval criteria, of course. Hopkins criteria, basically it is a criteria in which head and neck cancers, they are evaluated of squamous cell carcinoma, whether the disease is present or they are not. Because usually these patients are treated with radiotherapy, the remaining inflammation, the remaining disease that have to be differentiated with the help of PET, FDG PET. and therapy response is important for the oncology people. So that was introduced somewhere in 2014. It's almost 10 years. And here in what they were like comparing it with, first of all, the tumor sites, whether it's primary or whether it's lymph node. And second, activity present FDG uptake in the internal jugular vein. And third is the liver. And a score is assigned for the primary tumor and metastatic lymph nodes. So here, Hopkins criteria is from Johns Hopkins University. So Hopkins criteria 1, when uptake is less than internal jugular vein. And of course, we need a contrast study in order to identify the vessels and in order to mark them and calculate the SUV overhead. Then Hopkins criteria, uptake in IGV is like less than liver, a likely metabolic complete response if it is there in the lymph nodes or in the primary site. And Hopkins criteria 3, when ROI is slightly uptake in more than liver or diffuse, then again, if the radiation has been given, then it's a post-radiation inflammation rather than a tumor itself. While on the other hand, these two, uptake mortality greater than that of the liver and focal, these two have to, then it will be called HC4, and usually it is like residual disease. And if it's like 5, then the uptake is much more than liver, and it's also focal, then definitely it's a residual tumor. So in these 3 will be like post-therapy changes, and these 2 be residual disease. So just to make you understand what I have already enunciated, the baseline scan, primary tumor here you can see, and lymph nodes which are present, it's an FDG image, and metastasis. And after certain time, when the radio chemotherapy has been completed, you can see there is complete resolution of a tumor here, but there's like lymph nodes, they are still positive. So it's a Hopkins score 5, and persistent metastases are there. Here you can see. Though it has shown reduction, but it is still present. Again, another case in which a lingual tumor is there in here with metastasis in the neck nodes on the left side, and after a certain period of chemoradiotherapy, re-evaluation was done. The treatment response is there here in the primary site, but tumors are still present. So, post-therapy Hopkins criteria on FDG may identify clinically unsuspected residual disease in up to like 20% of the patients. So, this is very good criteria. We can, utilize it. And if we look at since 2014, multiple papers have been published, and they have validated these scores altogether in all the post-therapy or therapy response, post-treatment criteria. So coming to Duville, which is like there for the last now almost 15 years now, back in 2009, now it's a classification system which reliably describes the residual disease of FDG in lymphomas, whether it's non-Hodgkin or Hodgkin's lymphoma. So here we have got 2 reference points actually. One is mediastinal blood pool. Usually you withdraw it on the arch of aorta, and we spare the aortic walls, and only the blood pool is measured. And liver, somewhere in segment 6, 7, where no other disease is present, no other disturbance from the guts or like from the kidneys. So there we draw these ROIs. So again, similar to that Hopkins criteria, we have got 3 grades in which we call them negative, and 2 grades in which they are positive. So here you can see anything less than liver or equal to liver is negative, and if it's moderately higher than liver or markedly above the liver, then it will be called positive. Just to show the example, Deauville score 1, that negative, you can see the CT showing some nodes present here, and but they have got very low activity and less than liver. So they are all called negative. While on the other hand, if it's more than liver and it is showing much more high activity, then 4 and 5 Deauville scores are given. So according to that, Deauville score 1 to 2, 3 will be no lesions, no bone marrow involvement, complete response. Then partial, when 4 or 5 will reduce uptake from the baseline, residual bone marrow FDG uptake reduced from baseline, no new lesions, then we call it partial response. Stable disease, I will talk about later, and progressive disease, anything which is showing new lesions, whether and the increased uptake as compared to the baseline, then we have call it progressive. And if there's nothing like, then it will be called not fitting in here or here, then stable disease. So whenever we are using persist criteria and we are using like Deauville criteria, have to take certain things into account. First thing, we should be having the same scanner, acquisition algorithm, the reconstruction software and protocol, baseline and follow-up, so that you can report the scoring in a better way. And then we have to make sure that fasting is there 4 to 6 hours and glucose levels are like measurable less than 200. Uptake period, usually we know that we cannot ensure that exact same time is patient is imaged at the time when maybe we have got a heavy list, we have got a problem with our scanner, but we try to make it like 50 to 70 minutes after FDG injection, and then of course the Deauville criteria will be easily applicable. So role of interim PET for the assessment of treatment response, that is important, that if you start at the baseline, we have got certain number of cells which are showing FDG uptake, and over a period of time, when the end of therapy, the cells may be like getting killed and complete cure is achieved. And on the other hand, we have got certain group of patients in which the response to the treatment may not be very good. So here the usual size at the diagnosis and the cure, somewhere in between is the detection limit of PET. So in these two A and B groups, we have got decrease of uptake on the cancer cells, which is rapidly decreasing, and they are like lying within the low detection limit of PET. These two will ultimately go towards cure, and that's how the prognostic value of Deauville criteria and PET is established. On the other hand, if we have got, sorry for that. Okay. So here we can see that the response to the treatment is not good enough at interim PET. That's the green line, and you can see that it's gradually going down, and when interim PET, usually after 2 to 4 cycles we do, and we still find evidence of disease, then we call it like they're a non-responder, and maybe the cure will not be there till the end of the intended treatment. So escalation of therapy after 2 to 4 cycles or de-escalation of therapy is decided on these criteria by the oncology setups. So one thing, this is lymphoma response to immunomodulatory therapy criteria LYRIC that was proposed in 2016. As I've already mentioned, the Lugano criteria and Deauville criteria, which I've already mentioned, there is slight change because of the immunotherapy. In the tumor response is not that like of routine chemotherapies, and these checkpoint inhibitors may cause increase in availability of FDG to the tumor cells, whether or in the surrounding inflammatory areas. Here, for example, if conventional cytotoxic therapy, the size FDG uptake goes down, but in we are talking about immunotherapy, then there will be edema. Apparently, these cells which are non-cancerous, they will take FDG uptake, and we can see something like tumor flare phenomena. And we have to be careful about that, labeling the patient in such case when immunotherapy is being given, then we should not be labeling the patient as having progressive disease. So 4 possible response patterns in immunotherapy are like shrinkage of the initial lesions without new lesions, no change or stable disease, initial increase in total tumor burden and subsequent response, and response despite having new lesions. So in this case, Lugano criteria are a little bit modified in immunotherapy, and indeterminate response was introduced where there is an increase in overall tumor burden, interval development of new lesions, or growth factors on one or more existing lesions, interval increase is FDG uptake on one or more lesions without any morphological change. So here they say that if we label the patient as like IR, then a new PET scan is advised after 12 weeks or later. And if clinically indicated, you can do it earlier. So if pseudo-progression has to be ruled out with the help of PET, and the number of patients which are affected are less, but still you have to understand that this is some finding you have to give importance. So here you can see that these criteria are not yet been validated completely, but when we are interpreting our PET images, then we have to be careful about these. Here, for example, this is one patient, baseline, 4 cycles given, and immunotherapy, and 8th cycle. Here you can see the disease which is present here in the pelvis, in the inguinal area, left side, and in chemocycles, the number of lesions have increased. So after like 12 weeks, there is complete disappearance. Now we can call it complete remission. But on the other hand, if we have got disease which is decreasing but still present, and it will progress, and here we can label whether the patient is having complete response or progressive disease. Dual criteria, its modifications have been now utilized in multiple myeloma as well. In 2018, it was first introduced in Italian studies, and it for the response evaluation and monitoring and surveillance. Again, same criteria, uptake less than liver or more than liver. And here the impetus, these are called impetus criteria, Italian myeloma criteria for PET use in multiple myeloma, although it's not exactly a solid tumor, but plasmacytomas, like the sequel of multiple myeloma, their dual criteria can be used for the involvement of bone marrow, of the bone itself, of the nodes, extramedullary, etc. So metabolic status of the bone marrow, positive bone lesions, fractures, extramedullary disease, or paramedullary disease. They are all rated according to the Duval scores. And whenever we are preparing our report for in the case of multiple myeloma, then diffuse marrow uptake, focal bone lesions, lytic bone lesions, extramedullary, extranodal, all these diseases have to be mentioned whether they're present or they're absent. I think I should stop here.
Thank you.
Thank you so much.
Thank you very much. Do we have any questions from the audience, please? So thank you, Dr. Ahmed Qureshi, for highlighting the importance of different sets of criteria and different sets of solutions. Is our very good colleague from the Pakistan Institute of Nuclear Science and Technology, Islamabad. He is working as principal scientist over there, Dr. Nadeem Ahmed Lodi, and his expertise are on the targeted therapy agents that are upcoming now, and his talk will be on fibroblast activation protein inhibitors and emerging pan-cancer targets. So kindly come.
Thank you. Bismillah ar-Rahman ar-Rahim. Today I'm going to discuss about fibroblast active protein inhibitors and emerging pan-cancer target. As we know that we have a lot of success recently in the theranostic because of the lutetium dotatate and lutetium PSMA, which is approved by FDA and successfully into the clinics for the treatment of neuroendocrine tumor as well as a castration-resistant prostate cancer. So what would be the next promising target? And probably it would be a fibroblast active proteins. And as we all know that tumor microenvironment consists of the immune cell, vasculatures, extracellular matrix, and especially the cancer-associated fibroblast. And the cancer-associated fibroblast expressed with the markers, which is a fibroblast active proteins. And it is a type of type 2 integral membrane of glycoprotein of the serine protein families. And it expressed in 19% of expression on these type of cancer, especially the solid tumors, carcinoma, prostate cancer, breast cancers, head and neck, and colorectal cancer. So this is the one of the best image which was declared as the image of the year in SNM MMI in 2019, which was developed by the University of Hospital of Heidelberg in Germany, which showed that it can efficacy for the PET tracer with a variety of cancers. And this is a novel tracer which able to detect 28 type of different cancers in the patients. So what are the fibroblast active protein inhibitors? Basically, if you see here, this one is basically the lead compound which was published in 2012 or 14. This show very high affinity and selectivity towards the FAP. And then the researcher has improved this molecule by introduction of various functionalities into the molecule, especially with this nitrogen atom. They increase the affinity and selectivity towards the FAP compared to some other protease families of these which are in the tumor microenvironment. And then they introduce this difluorine type of groups here to further increase the affinity with the FAPI. So if you see that here, IC50 values, it show with the FAP with the number of 3.2 nanomole that show that it show very high affinity and selectivity towards the FAP compared to some other protease families which are in the tumor microenvironment. So these are all the difluoroproline type of molecule which show very high affinity with the. So there are, okay, we'll skip this one. I'll skip this one. So there are a variety of FAPI derivative which were established by different groups and being used in the clinics and preclinical studies. These are mostly FAPI4, which is very famous, like here, and this is FAPI46. The basic unit remain the same. However, the people are using different linkers and here to increase the affinity or pharmacokinetics. And especially this is a DOTA squaricasate FAPI molecule, which is developed by Professor Frank Roche. So they are all into the clinical or preclinical study for the evaluation of different in the different type of cancers. So the main issue with these FAPI derivatives are they the kinetics of these are very fast. They take into the tumor, they uptake into the tumor very fast, but it also cleared from the tissue within few hours. So this is the limitation associated with the fibroblast active protein inhibitor. If you see here, this one after 3 hours, it almost disappeared from the target. So here as well, after if you see the SUV max has decreased to the half within 3 hours. So that's the main limitations with the fibroblast active protein, because they show very high uptake, but it clear from the tissue very quickly. So that's not good for if you're applying theranostic therapy to the patient by using a FAPI derivative. It is not beneficial because it has a very low residence time into the tumor, and it clear from the tissue within a few hours. So what are the challenging? The challenging is main to prolong the residence time into the tumors, and how we can achieve that goal. We can achieve it by different strategy. We can use peptide instead of inhibitors, or we can modify the linkers into the molecule which show very good kinetics as well as uptake into the tumor. Or we can use some albumin binding structure into the molecule. So what the role albumin binder will play, it will bind to the albumin, and it keeps circulating into the blood, and with the time it will show enhanced uptake into the tumor. Another strategy, we can develop some FAPI dimers instead of one molecules. We can have a dimer, two molecules in a single molecular units. So these are the strategy which can be adopted to enhance the tumor uptake and residence time into the tumors. So what the people are now doing is they are doing it by developing some dimers. This is one of the dimer. This is a one unit, and this is another one FAPI derivative, and chelator is attached with this molecule here. This is Dotaga squaric acid FAPI molecule. If you see here, it show very good IC50 value. It mean it show very high affinity and selectivity to the tumor sites. So this is one of the example of this dimer. So this is one of the patient injected with the 20 MCI of radius tracer. This is the Dotaga squaric acid FAPI molecule dimer developed by Professor Dr. Frank Roche in the University of Mainz in Germany. So it show very good residence into the tumor until after 168 hours into the tumors. So this is one of the Dotaga squaric acid, as I described in the previous slides. So there is some other derivative here as well. Instead of this squaric acid, they just use a linear chain of this alkyl group to attach these two molecule attached with the Dotaga as well. This is a Dota squaric acid, the FAPI derivative. So why they developed this one? Because if you see here, this Dotaga squaric acid FAPI derivative, it show uptake into some non-targeting uptake into because it show very high lipophilicity. So that's why it show very intestinal uptake through the RES system. But these, the previous one, the molecule, the next generation molecule, they developed to decrease this lipophilicity into the molecules, so it clear from the non-targeted tissue very quickly, show very good distributions and profile into the human. So they did some of the clinical evaluation of this Dotaga's FAPI derivative into the breast cancer. If you see, they given this is FDG uptake, and this is the gallium Dota squaric acid FAPI molecule. It show good uptake into the lesions, into the mats of the patients, and they given with the lutetium dotatate of the 5 cycles of these drugs. it show very good response, and if you see that the whole body image scintigraphy, that the most of the lesion side, the tumor metastasis has been disappeared. So it's a very effective target for the treatment of the cancer with the dimeric, if we adopted a dimeric approach. This is another example of this. The patient is given 4 doses of lutetium DOTAGA FAPI derivative, and it show disappearance of some of the lesion on the sides. So it means that the best approach to enhance the residence time into the tumor is to prepare some dimeric instead of monomeric compounds. So the different group has developed these dimers. This is one of the example of Gothenburg University of Mainz by the Professor Frank Roche. They have developed these type of dimers. There are some Chinese groups who have developed this bio-oncoFAPI and these type of molecules as a dimer. And most of these molecules are into the preclinical or clinical stage for the evaluation of this FAPI derivative as well. So all of these dimers are working. We show very longer retention at good clinical outcomes. So conclusion is here is that it can be the one drug, single drug can effectively treat a variety of cancers by using this approach, by using the FAPI fibroblast active protein inhibitors. So our objective was as I told, most of these molecules are developed by some of the groups, which also they make it patent. Obviously, you can obviously use for the research purpose with our permission. However, if you want your own drugs to be into the clinics, so you need to have develop some of the derivatives. So we thought that we can develop some dimer molecules and we can do some clinical or preclinical evaluation of these dimers. So we adopted these molecules. We did some docking study of this molecule as well to check it whether it show high affinity with this FAP or not. So we selected these molecules and we synthesize it in our lab, and we radio label it with gallium-68 and lutetium-177. And we did some stability study, and further study is in progress, cell uptake study and biodistribution study in preclinical models like U87MG, which show very high expression of this FAP onto these tumors. So this is some of the synthesis scheme. I will not go into the detail because it's very complicated kind of chemistry involved, and most of here is a nuclear medicine physician. I will skip. So these are only the steps we used for the synthesis of these molecules. These are we prepared 2 derivatives, one with simple DOTA FAPI dimer, and the other one is DOTAGA FAPI derivative. These 2 molecules we have developed, and we characterize them and we purify it by using HPLC, radio HPLC, and we confirmed by using LCMS and NMR spectroscopy. And then we did the gallium labeling, and it showed very high radio labeling yield, 99.9% with the gallium, with a small amount of this precursor, even in the nanomolar range, like 40 nanomolar range. So it showed very good radio labeling. We confirm it by the radio TLC as well as the radio HPLC. And then we did lutetium study that whether these these molecules FAPI1 or FAPI2 show labeling with the lutetium. And you can see here these radio TLC scanners. It show this is for lutetium. This is labeled one, FAPI1, FAPI2. It show very good radio labeling, more than 99% by using radio TLC, and more than 95% by using radio HPLC. So we have done until this one work regarding the FAPI. So next future plan is to check whether it show high uptake into the cell lines which are expressed with the FAPI. Another one, non-clinical evaluation by using the tumor-bearing mice, which is U87MG, which show very high expression of this FAP, or PANC1, which also have expression of FAP. So by using biodistribution either or by SPECT-CT imaging, and then obviously if we have a good result, we can get into the clinical evaluation of these radiopharmaceuticals. And at the end, I would like to thanks to the Dr. Ali Raza Anwar, Chairman PEC, Member Science, Dr. Masood Iqbal, Dr. Shazia Fatma, DGNMO, Dr. Wasim, and my team, Mr. Kaisar Khan, Head IPD, and Dr. Irfanullah, Dr. Nasir, and Mr. Irfan. I would like to thanks to them for their continuous support. And also I would like to thank Dr. Inam and Dr. Shazia for giving the opportunity to talk here. And last but not the least, I would like to thanks to my colleague in South Korea, in Seoul National University, Professor Lee. And I recently visited there. I worked some part of this work in SNUH. So I would like to thanks to them for their support and their finance. And also this work is also the part of my IAS CRP. So I would like.
Thank you, Dr.
Nadeem, for sharing your incredible work. My question is about when it will be available to the medical centers for patients.
Actually, we are performing some clinical evaluation of these two drugs, and we are trying to develop some tumor model. Actually, tumor model take a lot of time, lot of efforts, and in Pakistan, as we all know that we don't have such facility here. So we don't have a tumor-bearing mice which are not available here, especially the skid mice or immunodepression, which is easy to develop the tumor model. So we don't have here. So we have to request to the other countries, like I have a collaboration and MOU signed with the SNUH. So we often request them to conduct the preclinical study for us. Hopefully, I told them, and one of my students is working in SNUH, so he's trying to develop some tumor model. As soon as we done the preclinical evaluation of these drugs, hopefully we will go into the to the clinics with your obviously sports. We need obviously we don't have a SPECT-CT available or PET-CT in our institute, so we need help from the medical center in order to have a clinical evaluation of these drugs.
Is there any further questions, please? So we have some more questions.
Dr. Nadeem, thank you so much for your presentation. This idea of dimeric form is really good. But my question is that if we are doing this study locally, do you have some plan how to purify the final product?
Sorry?
How to purify the final product?
How to purify? Okay. Actually, I did purification when I was on my fellowship in South Korea. Obviously, I have enough amount of this precursor in my lab. So for the time being, we don't need to purify it again. I have enough amount. We can do some preclinical and clinical evaluations because we need it in nanomoles, very low amount. So it labeled with gallium very efficiently, more than 99.5% radiolabeling efficacy. So, but in the future, obviously, we need a setup for the synthesis. Actually, myself is an organic chemist, basically, which turned into the radiochemistry, into the radiochemist or radiopharmacist. So, and we are in the process of in the acquiring of these instruments, which are used for the purification. Hopefully, in the future, we have this instrument, then we can make it in the bulk amount. Yeah.
Good luck, Nadeem.
Thank you.
Thank you, Dr. Nadeem Lodi. Our next speaker is Mr. Asif Shehzad. He is a medical physics graduate from PIAS, session 2001 to 2003. Currently, he is working as Chief Scientific Officer in Directorate of Radiation Safety at PNRA, with, having more than 20 years experience in the radiation protection and safety. He is also a member of IAEA Radiation Safety Standard Committee, and today he is going to deliver, or he will be highlighting the regulatory requirement of the PET cyclotron facility. I guess a very relevant topic.
Assalamu alaikum and good morning. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Dr. Shazia, President of Pakistan Society of Nuclear Medicine, for providing me this opportunity to present here the regulatory requirements for PET and cyclotron facilities. Here is the outline of my presentation. I will describe brief introduction of PNRA and then regulatory functions of PNRA, legislative and regulatory framework, PET and cyclotron facility, and regulatory requirements for this facility, and the regulatory requirements established in Regulations Park 908, and then the conclusion. Ionizing radiation is a type of energy released by atoms in the form of electromagnetic waves and particles. People are exposed to natural sources of ionizing radiation as well as in human-made sources. Ionizing radiation has many beneficial applications, including uses in medicine, industry, agriculture, and research. As the use of ionizing radiation increases, so does the potential for health hazards if not properly used. The government is responsible to ensure that radiation sources are used beneficially, safely, and ethically. So the government of Pakistan has established PNRA, Pakistan Nuclear Regulatory Authority, under PNRA Ordinance 2001. PNRA is an independent regulatory authority to regulate the nuclear safety and radiation protection in the country and extent of civil liability for nuclear damage and resulting from a nuclear incident. The mission of PNRA is to ensure that safe operation of nuclear facilities and protect the radiation workers, the general public, and the environment from the harmful effects of ionizing radiation by formulating and implementing effective regulations and building a relation of trust with the licensees and maintaining transparency in actions and decisions taken by the regulatory body. So for the activities, performing the activities of PNRA has established regional nuclear safety directorates and inspectorate across the country. So PNRA has its headquarters in Islamabad, where the main directorates, technical directorates and administrative directorates are within the headquarters. And we have three regional directorates. One is in Islamabad, and one is Chashma, and one is in Karachi. Along with these directorates, we have 6 regional inspectorates. One is in Peshawar, the other is Gilgit-Baltistan, and one is located in Muzaffarabad, Multan, and Quetta, and one inspectorate is under construction. Hopefully it will be functional in start of next year. So from these directorates and inspectorates, we are performing all the authorization and licensing and inspection enforcement activities to regulate the safe use of ionizing radiation. Here are the functions of PNRA to regulate the safe use of ionizing radiation. One of the main functions is the development of a regulatory framework. So PNRA is establishing regulations and guidelines, orders and policies for the effective control of use of radioactive material and use of ionizing radiation. The second function, main function, is review and assessment of with respect to licensing and radiation protection and safety of the radiation facilities and activities. Third one is the authorization and licensing of radiation facilities and activities. Along with authorization and licensing, we have another function of inspection enforcement. So these are the main. We have other functions of regulatory body, but these are the main functions we are performing for the safe use of ionizing radiation. Here is the legislative and regulatory framework. So it consists of 3 levels of documents. The first one is the ordinance under which PNRA has been established, which is issued by the government of Pakistan. And PNRA have issued other types of documents, which includes regulations and regulatory guides. Regulations are issued by PNRA, and these are mandatory. And regulatory guides are also issued by PNRA, but their nature is non-mandatory. Regulations establish the requirements for the safe use of radioactive material and use of ionizing radiation. And regulatory guides explains how, for the licensee, how to compliance the regulatory requirements. So, what is type of PET and cyclotron facility? So, according to our regulatory framework, PET cyclotron facility is a combination of 2 types of facilities where radioisotopes are produced and used. So, one type of facility is the nuclear medicine facility. PET scanner and use of radioisotopes for imaging is part of nuclear medicine facility. The second type is the radioisotope production facility. Cyclotron and production of radioisotopes is part of radioisotope production facility. So PET and cyclotron facility is a combination of two types of facilities. So two types of licenses are required for the operation of a PET and cyclotron facility. So PNRA has established a regulatory framework for the effective regulatory control of the radioactive sources within the country, and it also issued guidelines for the guidance of the licensee, so they can use these guides for their guidance how to compliance the regulatory requirements. So here are some the regulations which are relevant to the PET and cyclotron facility. The first one is the regulation for licensing of radiation facilities other than installations. So this is the main regulation, which is for the authorization and licensing of PET and cyclotron facility. The other applicable regulations includes regulations for protection on radiation, regulations on radiation protection, regulations on management of a nuclear or radiological emergency, regulations on radioactive waste management, regulations for the safe transport of radioactive material, regulations on security of radioactive sources, regulations on decommissioning of facilities using radioactive material, regulations on leadership and management for safety, and regulations, Pakistan Nuclear Regulatory Authority enforcement regulations, and regulations on licensing fee by Pakistan Nuclear Regulatory Authority. So here are the relevant regulatory requirements to a PET and cyclotron facility. So licensee can go through these guidelines before performing the activities of operation and waste management and decommissioning and physical and quality control of the facility. So one is the regulatory guide on preparation of license and authorization applications for radiation facilities and activities. This is the main guide which address the explain the licensing and authorization requirements. So applicant should go through this guide before applying for licensing and authorization from PNRA. The other one is the format and content of safety analysis report for radiation facilities, format and content of radiation protection program, format and content of radioactive waste management program for nuclear medicine medical centers, preparation of radiation emergency plan for radiation facilities and activities, format and content of decommissioning plan for radiation facilities, format and content of physical protection for radiation facilities having radioactive sources, and one guide is on format and content of quality assurance program. We hope we will develop a new guide for the guidance of licensee in the field of quality assurance program, and it is our work plan for the next year. So, as I mentioned earlier, that regulation PAG 908, the main licensing regulation. So all types of licensing and authorization with respect to radiation facilities and activities are covered in this regulation, and only the activities which are exempted under regulations on radiation protection PAG 904 are not part of these are not addressed in this regulation. So here is the licensing process. So first step in the licensing process is the notification to the regulatory body by the applicant it is very important from a licensing point of view that as any person who intends to establish a radiation facility or perform any activity with respect with the use of radioactive sources, he is required to notify the authority. So if he notifies the authority timely, so the licensing process may be initiated as early as possible. Submission, and the next step is submission of application for registration and acquisition of license along with required documents and licensing fee. After the review and assessment of the licensing submissions, the acquisition and the premises of the facilities are registered with PNRA, and acquisition license is issued to the applicant for the acquisition of radioactive source or radiation generator for his facility. After this inspection, on completion of installation and commissioning of the facility, inspections and investigations are conducted by PNRA, and the whole documents are reviewed and queries are generated by PNRA. If you have some deficiencies in documents, these are communicated to the license applicant. After the resolution of these queries and approval of documents, authority issued an operating license to the applicant. So the acquisition license is not for the operation of facilities. So under this license, you can only acquire and possess the radioactive source, but do not operate the radiation facility. So the licensing and documents which are required along with the application for nuclear medicine cardiology center, an applicant will submit safety analysis report, a radiation protection program, radioactive waste management program, radiation emergency plan, quality assurance program, and initial decommissioning of facility. And for manufacturing or radioisotope production of radioisotopes and radioactive material, one document will be added in, as mentioned, the other 5 documents. That is the physical protection plan for the facility. So after expiry of the license is issued on annual basis. On the expiry of the license, the applicant is required to apply for the license renewal along with the required documents and renewal fee. These documents are reviewed by the authority, and on its satisfaction, license is renewed for the facility. So here are the documents which are required at the time of renewal of the license. So at the time of renewal, the licensee will submit the updated list and occupational data of workers, updated information and documents as per Schedule 1, and updated inventory of radiation sources, and any other information and record as required by the authority. So sometimes the other activities are also performed by the licensee which are not covered under the license. So he should apply for the specific authorization before performing these activities. So these activities include any changes in the approved licensing documents, modification in the specification of radiation sources, shielding design, facility layout, safety and or security functions, import, export of radiation sources including used or refurbished radiation generators and devices containing radioactive material, local purchase of radiation sources including used or refurbished radiation generators and devices containing radioactive material, transfer or sale of radiation source to any other person unless the transferor possesses a valid license and both the transferor and transferee have obtained authorization from the authority. Transfer of radioactive material to a designated radioactive waste management facility, decommissioning of radiation facility, clearance of radioactive material or radioactive objects, health screening and biomedical research involving radiation exposure to humans, and any other activity as may be determined by the authority. So here is the process for obtaining the specific authorization. So some authorization require the authorization fee and some are free of cost. So applicant will submit the licensing fee, authorization fee and relevant documents, and review. After the review and assessment of the submissions by the authorities, a specific authorization is issued to the applicant. So now come to the conclusion. PNRA is controlling, regulating and supervising all matters related to nuclear safety and radiation protection measures in Pakistan. PNRA has established regulatory framework for effective control over the use of ionizing radiation. PNRA is striving hard for achieving the ultimate goal of protecting the workers, the public and the environment from harmful effects of ionizing radiation. Thank you very much.
Thank you very much, Mr. Asif Shehzad, for highlighting the regulations required for the establishment of a PET facility. Do we have any questions from the audience, please? So I think no questions. Thank you.
Is co-chair allowed to ask one question?
Yes, sure.
Can I, sir? I just wanted to ask something, that the license renewal, or like when we apply for some license or for care, can't PNRA do it, like the system can be online, so it will be easier for the people, like registration or some licensing or applying for the renewal, like if like other things, you know, like driving license or something like that, we do it online, get the appointment or fill the documents. It will be easier for you as well to manage the data. It's just a question.
Yes, we are already working on this for the online applications and the processing of the applications online for the convenience of the licensee. So it is already our in plan, under process. So in future we hope you can apply online.
Thank you. Thank you, Mr. Asif Shehzad. Just one comment, that the online system may be user-friendly, please. Because in Pakistan, when the online systems are available, they are mostly not user-friendly. Thank you. So our next speaker is Ms. Anila Riaz. She is also working at Directorate of Radiation Safety at PNRA. She has more than 13 years involvement in regulatory documentation for medical radiation facility and licensing of manufacturing of the radiation sources. She will be sharing her experience on the requirements of management system of nuclear medicine facility in the light of regulations PARC 921. So over to Ms. Anila
Riaz. Thank you for a nice introduction. Okay. I think I can skip these slides now. So this is the layout which I will follow in my presentation. We will see a brief introduction of management system, then IAEA standards regarding management system, requirements in regulations PARC 921. Then we will discuss main contents of the management system of nuclear medicine facility, and in the end I will summarize my presentation. So what is a management system? Management system has many different definitions in different documents. So if I put it in most simple way, I will say that it is a set of policies, processes and procedures used by an organization to achieve its goals and objectives. Or in other words, it is a systematic organization of activities. So one way or another, it is proved as an effective tool for the management of an organization. Management system provides us guidelines that serves as to support for all employees in their day-to-day activities. In management system document, you can find vision, mission, goals, objectives of an organization, what are the tasks they have to perform, what are the resources, distribution of responsibilities, and how the tasks have to be performed. So in the presence of such written instructions and guidelines, the possibility of errors, and especially the errors that could lead to incident or accidents, they could be reduced to minimum. So we can say that in the presence of an effective management system, all the possible objectives of an organization operation could be achieved. Those objectives could be safe operation of the facility, product quality. In your case, that will be quality services to the patients, your patients' trust in your facility, in your doctors, effective resource management that leads to financial success. That is an ultimate goal to every organization operation. Then, of course, regulatory compliance. So let's see some now IAEA standards regarding management system. As you know that PNRA developed its regulation in the light of IAEA safety standards. So if you look into IAEA safety standard, then the top level document is safety fundamentals. Under this document, IAEA developed safety requirements, which are further divided into general safety requirements and specific safety requirements. And under these requirements, then IAEA established safety guides, which provides the guidance and recommendations on how to implement these requirements. So the top level document, Safety Fundamentals, it has 10 principles, and principle 3 is about the leadership and management system. It states that effective leadership and management for safety must be established and sustained in organizations concerned with and facilities and activities that give rise to radiation risk. Under this principle, IAEA has established safety requirements, GSR Part 2, with the title Leadership and Management for Safety. And this document describes the concept of 3 balanced elements: leadership, management, and culture for safety. It further emphasized the fact that all these 3 elements are interrelated and they cannot be effective without one another. So on the basis of this document, IAEA document GSR Part 2, PNRA has developed its regulations, PARC 921, with the same title, Leadership and Management for Safety. These regulations were Gazette notified in February 2022, and these regulations are applicable to all the facilities and activities that give rise to risk from ionizing radiations. So, right from nuclear installations to small radiology facilities with a single X-ray machine, all facilities have to comply with the requirement of these regulations. It has total 18 requirements, and like I said, it is based on IAEA GSR Part 2. So it also focuses on 3 elements: leadership for safety, management for safety, and culture for safety. As per my topic, I will stay on the requirements regarding management for safety. So as per these requirements, senior management of the facility is responsible for the establishment, implementation, and improvement of management system. It has to develop a safety policy, and under that safety policy, goals, objective, plans, strategies of organizations will be established. Senior management is responsible for interaction with interested parties. It has to identify the parties on whom there could be impact due to facilities operation. Then there is requirement regarding integration of management system. Senior management has to consider all the factors that could have impact on safety while developing management system. Then there is a requirement that every facility has to document its management system, and of course it will be with the graded approach depending on the risk associated with the facility. Then there are requirements regarding management of resources, management of processes, management of supply chain, measurement, assessment, and improvement of management system. As I said that there is a requirement that every facility has to develop its management system. So the question is, what should be the format and content of that document management system? So PNRA is in the process of developing the guidelines for this document, and it is in approval phase. And hopefully in 2 or 3 years, we will also develop a detailed regulatory guide on the subject. So for the time being, as per guidelines, the document of management system for a nuclear medicine facility, it should have these contents: measures for demonstrating leadership for safety, organization description, documentation and records, resource management, supply chain management, measurement, assessment and improvement, and safety culture. I will describe them in coming slides one by one. The first is measures for demonstrating leadership for safety. In it, senior management has to give a high-level commitment in the form of safety policy that they will give safety the overriding priority on all other competing goals. And it should not be only the statement, it should be reflected in their behaviors, in their actions, in their decision making. They should establish organizational values, and these values should be known to all the workers, and it should be reflected in their day-to-day activities. And then there should be mechanism of accountability against the assigned responsibilities in the facility. Next is organization description. In it, you are required to give the organization structure, identification of key positions, what are their authorities, what are their respective responsibilities. Then you need to identify external and internal interfaces. In case of internal interfaces, the other departments which you need to interact with for the operation of your department. And in case of external interfaces, you need to identify other organizations that could be suppliers, service providers, manufacturers, vendors, even regulatory body. So you need to identify a focal person and lines of communication for effective interaction with them. Then there is document control. Every organization has lot number of documents that could be policy documents related to tasks and functions, work plans, reports, processes, procedures. So there should be a process to control all these documents. It should not be like that any person on any day stand up and say this is the document and this will be being implemented from yesterday. It should not be like this. You need to develop a mechanism to manage the creation, review, modification, accessibility, issuance and distribution of document. Then you should ensure that all the documents are up to date and the information in it is reliable and approved. And if you find the need to revise any document, then the revision will be subject to same level of approval as the initial document. Next is record control. In it, all the activities which you are performing in your organization that has an impact on the safety, their records need to be maintained and controlled. And these records should be identified, categorized, registered upon receipt, placed according to location tags, retrievable. And one more important thing is that you need to identify the time period for each record. Definitely you could not maintain all the records for indefinite period of time. So you need to identify the time period depending on the significance of the activity and corresponding record. Next is resource management. Senior management is responsible to provide necessary resources to carry out the activities of the organization. That could be any type of resources, financial resources, administrative resources, technical resources, knowledge resources, and of course, human resources. They should make an arrangement for adequate staff at the facility. Then they should be competent enough to carry out their tasks and functions. And if you find some deficiencies in their competence, then you should make an arrangement for their training. And it should not be only one-time activity. As we heard throughout this conference that new radiopharmaceuticals are coming in the market, new imaging equipments are being introduced, policies and procedures are being changed. So you need to keep your workers up to date so that they can perform their activities effectively. Then there is requirement of supply chain management. Arrangements should exist with vendors and suppliers for specifying, monitoring, and managing the supply of items, products, and services that may influence safety. In your case, you need a continuous supply of radiopharmaceuticals, so you need to make arrangement for that continuous supply. And you should make sure that the suppliers, they should adhere to safety requirements, and you should have a clear understanding and knowledge of the product or service being supplied so that you can evaluate those products according to the requirements. Then there is a requirement of safety culture. Culture in simple word is the behavior of the individuals or the way they are doing things around. So safety culture is how much importance they are giving to safety while performing their activities. So to promote and encourage a positive safety culture in your facility, you need focus on following factors like commitment. There should be commitment to safety in all activities and decisions, good working environment that should be supported with the teamwork, trust, open communication, responsibility, accountability, and most important, encourage questioning and learning attitude at all levels in the organization, especially at the bottom level. Then once you have developed the management system, it should not be like you can now keep it in the shelves. There should be a mechanism for the monitoring, for the assessment of its effectiveness, and accordingly, if you find some deficiencies, then you need to improve those areas. So these are the mechanisms of assessment. You can perform self-assessment, independent assessment. In case of self-assessment, department itself can perform its assessment, while in case of independent assessment, it can be in the form of internal and external audits. In internal audits, some other department of the organization can perform your assessment, while in case of external audits, some other organization will perform your assessment. That would be like peer review. Then there is management review, top management of your facility that needs to review the management system periodically, preferably once in a year, to ensure suitability, effectiveness, and its ability towards achievement of organization's objective. The management review may include input from self-assessment reports and audit reports. And again, if you find some deficiencies, then you need to make corrective action plan, and you need to make improve those areas where you find the weaknesses. This is again, the mechanism should exist for evaluating processes for the effectiveness, and should document causes of non-conformances of processes, corrective actions necessary for eliminating the causes of non-conformances, and of course actions for preventing the occurrence of non-conformances in the future. So that's all about the contents of the management system. The takeaways are Regulation Park 921 sets requirement for establishing and assessing a management system. Safety can be ensured by focusing on 3 pillars: leadership, management system, and safety culture. And management system plays a very important role in effective, efficient, and safe operation of a regulated facility. Thank you.
Thank you, Ms. Anila. Do we have questions from the audience, please? Or from the co-chair?
I have one if there's no other.
Thank you very much for a very informative talk. Since in our hospitals, I think many of our hospitals which are dealing with the radiation, they have some kind of management system going on, like if it is ISO or JCI or some other management system, or they are following IAEA, Quantum or Quadral or Quattro, whatever it is. So why do we need to have another set of documents for management thing, and then because it is just adding documents and documents and documents?
Yes, you are right. There are many things common in all those management system, requirements of management system, like ISO. If we look into ISO and IEA, GSR Part 2, then many things are common, like the concept of leadership, of safety, processes, procedures. They all are common. They all require these things. But the main difference is that the other standards are focused on quality, just quality, and they are more focused on the customer satisfaction. You need to establish all those processes and procedures which could satisfy your customers. In your case, definitely they will be patients. While GSR Part 2, that is focused on safety. It says that safety is your topmost priority, and all other factors could complement that factor, but you have to keep the safety on priority, and you have to document you have to make the document in a way that safety should be the priority.
So my added point is the safety depends on the quality of services. So you have the quality management systems in your hospitals. So why don't we make it part of ISO document instead of having a separate safety document? And the PNRA should accept that, just add the safety part in it. Because if we are doing the quality practices, it is all automatically translating into safety.
Mm-hmm. Yes, while developing this document, we have considered all those standards as well, and the factor of quality is also included. That is part of it, and of course safety, we have focused on safety as well. But your point that other factors, they could be combined in a single document. In our document, at least, all the other factors are combined. And now I have also learned from somewhere that all these standard owners, ISO standard, GS, IEA, they are working together to make a common standard. And hopefully in future, we will get rid of this, maybe, lot of documentations.
Dr. Shazia, she read my mind. I had the same question in my mind. Thank you.
I was expecting this. Thank you.
Thank you very much for the informative talk, and it's hopeful to know that we are going to have a single document rather than 4 or 5 documents. So now I would like to call upon the co-chair for summarizing the talks and give her opinion about them.
So I will quickly wrap up today's session, this session, scientific session 7th of 9th annual conference. We had 5 talks in this session, and they were all very well informative talks, and few of the talks were very much relevant with my field, being medical physicist as well. So the first talk was given by Dr. Humayun Bashir regarding, I understood part of it, and it was good, and people were enjoying, and it was quite informative as well. It was he highlighted different tools for fracture risk assessment, and the second talk was given by Dr. Ahmed Qureshi. I would just sum up in a way that in Urdu, डॉक्टर अहमद कुरैशी के लिए बोलना ऐसे है जैसे आप सूरज को चिराग दिखा रहे हो. So it was again informative talk. The third one was Dr. Nadeem Ahmed Lodi, again very well versed in his field, and quite informative talk given by Dr. Nadeem Ahmed Lodi. The final 2 talks, which were given by PNRA, I think they were very relevant with us, with being working in nuclear medicine centers, that all of us has to go through PNRA documentation. So we should be familiar with the processes, with the different departments, office bearer, where to go for if we are applying for some renewal or registration. The talk given by Mr. Asif Shehzad, the Chief Scientific Officer, that was very interesting and informative, sort of a review of how PNRA, the working groups of PNRA. And then the last talk was given by Anila Raza. Somehow I am her teacher as well, so it was very nice to see Anila Raza presenting. And again, nice talk about information management system. So definitely all the sessions went very well. Thank you so much.
Thank you, Ms. Noreen. Now I would like to request the chairperson, Dr. Hafiz Khosrow, to comment on the session.
Thank you. This is the end of this last session. Wonderful 9th annual conference, which is going to end today. All the talks were very wonderful and very nice. Humayun Bashir on molecular bone imaging and fracture risk assessment opened the new era for this research, as well as our mentor, Dr. Ahmed Qureshi, response assessment in solid tumors. There are many things to be covered in this topic, and there are many research things to be done in these things. Another topic जिसने मुझे impress भी किया वो FAPI preparation है in PINSTEC, and I hope and I pray that we could stand with all these things, and my prayer is that we may prepare this very soon, FAPI novel agent in Pakistan, inshallah. Regarding PNRA personnels, Asif Shehzad Saab and Anila Raza, both the presentations were very good, although regulations seem slightly difficult for us, but these are basically for safety of public as well as for safety of employees and health personnel which are working over there. With this, we end this session. Thank you, everyone, participants as well as speakers. Thanks a lot.
So now I would like to invite Dr. Shazia Fatima, President PSNM, to deliver the souvenirs and the certificates to our worthy speakers and chair and co-chair. Now I request Dr. Ahmed Qureshi to please come on the stage to receive his souvenirs. Dr. Nadeem Ahmed Lodi. Mr. Asif Shehzad. Mr. Asif Shehzad, kindly come on the stage. Ms. Anila Raza. Now I request Dr. Hafiz Khushnasib to receive his souvenir for chairing the session. Ms. Noreen Marwar for co-chairing the session. And myself, Dr. Amreen Khavar, for moderating the session. Now this comes to an end of this session. Now I request Dr. Azra to continue with the next session.
Thank you, Dr. Amreen. Bismillahirrahmanirrahim. Assalamu alaikum. We have reached the highlight of today's event, the closing ceremony and the much anticipated award distribution for oral and poster presenters. I would like to invite Dr. Shazia Fatma and Dr. Babar Imran to come on the stage for this official closing event. I request other members of EC to come on the stage for this official closing. Kindly come on the stage, Dr. Farkhanda, Dr. Sadiq, Dr. Zahir, Dr. Inam. Please come on the stage. Before we conclude, I would like to take a moment to express our deepest appreciation to all the organizers, invited speakers, volunteers, and all of those unseen people who made today possible. It has been an incredible journey, and we are thrilled to end on such a high note by recognizing the excellent achievements of some very talented individuals. To honor those who have excelled, we will now proceed with award ceremony. Let's celebrate each other's accomplishments. I would like to call Dr. Sadiq for announcement of poster presenters. Dr. Sadiq, please come forward and announce the winners as well as for other presenters for certificates. Dr. Sadiq.
Bismillahirrahmanirrahim. Assalamu alaikum to all of you. I am here to announce the results of e-poster presentation done yesterday. But before this, I invite the three evaluators to collect their certificates of appreciation. First of all, Dr. Iftikhar Alam. Dr. Khush Naseeb. Dr. Amreen Khavar. And the first prize of 10,000 cash goes to Mr. Dr. Asad Ali from Inmol. Second prize goes to Dr. Sumaira Mushtaq from AEMC Karachi. Second prize is of 7,000 cash prize. Third prize of 5,000 cash goes to Dr. Hira Tahir from Inmol. Now we will give the appreciation certificates for all the poster presenters. First, Dr. Marhiya Aslam. Dr. Bushra Sabeen from Karachi. Dr. Anika Jabeen from AEMC Karachi. Ms. Sania Shafiq from Sinar Quetta. Dr. Simab Safdar from Noor Islamabad. Mr. Javed Ali from Sinor, Sawat. Dr. Lubna Jadoon from Karachi. Dr. Sajid Hussain from Inmol, Lahore. And Dr. Muhammad Adil from NMCA FAPI. Now I invite Dr. Farkhanda for the results of oral presentations.
First, I will invite the evaluators of the free paper presentation for the certificates, Dr. Shehzad Afzal, Pinham Hospital. Dr. Awais Gill, Pinham Hospital. Dr. Salman Habib, Kiran, Karachi. Now I am going to announce the top 3 position holders of the free paper oral presentation. Dr. Murk Lagari from Noreen Nawabshah got 3rd position. Zahid Islam from Pias got the 2nd position. And Dr. Adil from AFIP got the 1st position. Now I request the rest of participants for certificates. Muhammad Wakar from Noreen. नहीं है अच्छा फातिमा रेदा Rana Fatma from AFIP, Sania Shafiq from Sinar, Amna Nasir, Sinor, Zishan Sikandar, AFIP, Varda Ashfaq from Inmol Hospital, Lahore, Hira Tahir from Inmol Hospital, Lahore, Dr. Simab Saftar, Now I request Dr. Azra to continue certificates. Now I request Dr. Azra to take up the rest of the closing ceremony session.
ये जो आपने There are few tokens of appreciation for our participants as well as guests and invited speakers. First of all, Dr. Tania Jawar from Pinam. Dr. Nadeem Lodi will receive her certificate on her behalf. Dr. Ali Raza Naqvi, Dr. Sajid Mushtaq, Dr. Mehdi Raza, and Dr. Salman Habib. Now I would like to invite Dr. Shehzad Afzal from Pinam for special appreciation. I think he is not here, so anyone on his behalf can receive his. जी वो announce हो गया. Now I would like to request Dr. Shazia for certificate of appreciation for Dr. Babar Imran and Dr. Muhammad Naeem from Pinam. On the behalf of Dr. Muhammad Nadeem, if there is from Pinam, please receive his certificate. Dr. Naeem, Dr. Muhammad Naeem. Now, I would like to invite Dr. Shazia Fatma. Continue. This is the end of award and certificate distribution, and now I would like to invite Dr. Shazia Fatma for vote of thanks. Ma'am, please.
Before giving the final vote of thanks, I would request Dr. Babar Imran to say a few words before the closing of this meeting.
Bismillahirrahmanirrahim. Last year in Rawalpindi, when it was suggested that Faisalabad may host this year conference, I was quite skeptical since it's difficult to gather different professionals from various parts of the country to this city. So I thought that it would be very difficult, or maybe very few people will come. But it was fantastic. It was just saying like, wow, the hall is full. The workshops, the first night dinner at Pinam, and then inauguration, and then whole long day yesterday. And then the lavish dinner hosted by PSNM at Serena. And finally, this part. It's really marvelous. It has increased my blood, not blood pressure, just blood. So thank you very much. All the credit goes to the leadership of Dr. Shazia Fatma and the untiring, endless efforts put by the executive committee. And of course, nothing is decorated without the audience, all of you. Thank you very much for coming to this city. And now I have courage. Maybe next time again you can come to the Faisalabad for the next meeting and the conference as well. Thank you very much.
Thank you very much, Dr. Babar, for the kind remarks. I want to have few announcements before I go for the final closing speech. This is not our mandate to announce the place of the next PSNM, but since in last PSNM annual meeting in Rawalpindi, we decided that instead of having it after every 2 years, we will have the annual meeting annually, and annual meeting annually is like oxymoron. So, so on that note, we had this Faisalabad meeting, and as you said, you were very skeptical. We were more skeptical about Faisalabad because we thought it's a national meeting, but if it is a national meeting, people will not come, so we have to invite a few international delegates, and then to bring them here, and everything is like, we put few efforts and then you helped a lot, and this thing materialized eventually. So for the next meeting, I think this EC can only do one thing, that we can have the meeting in November 2025, because October we have experienced that because of Breast Cancer Awareness Month, and also because next Shaukat Khanam meeting is also coming in October, so we have decided that next meeting we will have in November 2025. And the venue maybe is the choice of the next EC, but if we go by turn, so we can think of Lahore or we can think of Peshawar, if everything goes well. So this is one thing this EC is just suggesting, and it will be the mandate of next Executive Council to decide about the venue and the exact dates in November. But we are locking November 2025 for the next PSNM, 10th PSNM annual meeting. So my distinguished guests, esteemed colleagues and participants, as we conclude this year's annual conference of Pakistan Society of Nuclear Medicine, I want to extend my deepest appreciation to each and every one of you who contributed to making this event an outstanding success. Your presence, insights, and sheer expertise have made this gathering truly enriching and impactful. The past few, or 3 days or 4 days, I have lost actually the count. The past few days have been filled with enlightening discussions, innovative research, and shared goals that underscore our dedication to the advancement of nuclear medicine in Pakistan. Over the past few days, we have had the privilege to exchange knowledge, engage in thought-provoking discussions, and witness groundbreaking advancements in nuclear medicine. The presentation, research, and collaborative spirit demonstrated here will without a doubt contribute to the continued growth and excellence of our field in Pakistan. To our esteemed speakers, thank you for sharing your expertise and insights. Your presentations have enriched our knowledge and encouraged us to push the frontiers of nuclear medicine even further. A special thanks to our local hosts. वो मैं पहले भी कह चुकी हूँ, लेकिन I think एक formal कहना बड़ा ज़रूरी है. To our local host and conference chair, whose meticulous planning and hospitality have made this gathering smooth, enjoyable, and impactful. The first night dinner, which was hosted by PNRA, when we attended it and we thought, oh my God, what we will do in next 3 days, because we are not going to touch that standard. But hopefully we tried, and we have met
maybe the lower level of your standard set by you. Your hard work behind the scenes have not gone unnoticed, and we are truly grateful for your commitment. To the Executive Council member, and especially Dr. Inam, thank you for your guidance. It should be Dr. Inam saying to us so many things. And steadfast support. Your leadership have been instrumental in bringing us all together in pursuit of a shared vision. And it is this collaborative spirit that strengthens our society year after year. To all the participants, ये जो सारे बैठे हैं और अभी तक बैठे हैं, thank you for your enthusiasm, engagement, and valuable contribution to the conference. Your dedication to the field and active participation make this gathering a vibrant forum for learning and collaboration. It is your passion and involvement that strengthens our society and drives us to meet the healthcare needs of our communities and set the higher standards. And finally, to our industry partners, thank you for your generous support. And partnership. Your collaboration is vital to advancing nuclear medicine in Pakistan, and we look forward to continuing this relationship in years to come. Agle saal ke liye aap taiyar ho jaiye, please. Once again, thank you for being part of this conference. I hope this experience has been rewarding for you as it has been for us. I look forward to our continued collaboration and hope to see you at next year's conference and me sitting over there and somebody else thanking you at the podium. Wishing you safe travels, and I look forward to our continued work together in future, and may we all continue to advance and serve the field of nuclear medicine. Thank you. Since my special thanks to, because Dr. Arif and only Dr. Savas is sitting over here, and my special thanks goes to them because they have traveled right from ENM. Dr. Savas came after ENM, and he is here, and he will be traveling to Islamabad with us, and then from here he is catching his flight. In Pakistan, we don't get many experts, but the people who come, I think they can carry the message that we have a very vibrant nuclear medicine society and very enthusiastic nuclear medicine community. So when you spread this message, you will actually highlight the role of nuclear medicine, Pakistan Society of Nuclear Medicine in the societies of world. And since you shared so many insights about how we can go about the Pakistan Society of Nuclear Medicine, we will definitely think about that and act on that. And last but not the least, Dr. Arif, unke liye bas yahi kafi hai ki whenever we invite him, physically or online or for webinar, he's always there for us. So special thanks to Dr. Savas and Dr. Arif. And I think that last announcement is that let's go and have a cup of tea and depart on a very high note.
All 6 poster winners and free papers winners, please contact Dr. Adil to collect your hampers. All 3 poster winners and all 3 free papers winners, first, second and third, please contact Dr. Adil to collect your hampers.